The opening ceremony is going to start shortly, so please be seated. So, distinguished guests, panelists, presenters, ladies and gentlemen, good afternoon and good morning for those of you who are following us online from Western Hemisphere. My name is Makti Ondafash. I'm a research and publication advisor at St. Paul's Institute for Reproductive Health and Rights. On behalf of the organizing committee, I would like to welcome you all to this RH symposium, which is going to be conducted with a theme of reproductive health care provision amid COVID-19 pandemic, lessons learned and the way forward. In this afternoon, we are going to have a panel discussion, 4 oral presentations, and finally, we're going to have also a state-of-the-art lecture towards the end of the day. So I would like to thank you all for joining us in person and also virtually for this for the various deliberations that we are going to have today. At this time, I would like to call upon Dr. Tasfaye Hurissa, Associate Professor in Obstetrics and Gynecology, Director of St. Paul's Institute for Reproductive Health and Rights, to make an opening remark, and at the same time to invite a guest of honor to officially open the symposium, and at the same time to make or to deliver the keynote address. Please welcome Dr. Tasfaye Hurissa.
Thank you very much, Dr. Makati. Distinguished guests, speakers, panelists, presenters, and all fellow women healthcare providers. Good afternoon and good morning for those of you who are using a different time zone. I'm very delighted here to welcome you to the 3rd annual Reproductive Health Symposium. 3 years back, we started this annual event with so much optimism and energy. Many partners, scholars, and government officials have put their time and energy into its success. A month later, after the symposium, the first case of COVID-19 was reported, and the world went into shock. The world was defeated like never before and continues to be challenged. Major national and global events were postponed, even some of them were indefinitely stopped. But we immediately adapted to a new reality and way of working. Regardless of the challenge, we underwent the 2nd National RH Symposium a year later. Standing here on the 3rd RH Symposium, I want to congratulate all of you for staying strong, for believing in reproductive health and rights, for looking into possibilities beyond the challenge despite the hindrances. I want to congratulate you for your persistence and perseverance, for your commitment and dedication to continue being a voice for women's health, for your resilience during this challenging time, and for continuing to provide quality SRH services amid the global pandemic. We are in an exceptionally challenging time of our years. We are suffering from the continued pandemic, low COVID-19 vaccine uptake, vaccine inequality, protracted war, internal displacement, famine, and severe humanitarian crisis. We also lost colleagues, brothers, and sisters to COVID-19 who were serving people in the middle of the crisis. The war, added to the global pandemic, has amplified the existing deep-rooted challenge to our girls and women by further straining access to sexual and reproductive health services and disproportionately increasing rape and sexual violence. Both local and international studies have demonstrated that the rate of unintended pregnancy, unsafe abortion, and abortion-related deaths have markedly increased during this period. We will certainly pass through this challenging and through this challenging time, and a better day will definitely come. As we are challenged by circumstances, it's also an opportunity to be part of the solution. We are fortunate to continue serving our community in providing clinical services, creating an innovative solution, making a strong policy, and ensuring that all necessary commodities reach those in need in the face of all adversities. This year's symposium will be conducted under the theme of sexual and reproductive health services amid the COVID-19 pandemic, lessons learned and the way forward. We will share best practices and new scientific developments in women health. I hope you will enjoy the symposium and also take many lessons from it. Saying this, I want to thank everyone who has supported our journey until this day. This symposium was impossible without the selfless support from all partners and stakeholders. I want to thank particularly the head of Department of OB-GYN at St. Paul Hospital, Dr. Delayo Bekele, who has been instrumental until the last day in mobilizing faculties and all partners. I also want to thank the scientific committee, the fundraising committee, the organizing committee for your hard work and dedication. I also extend my gratitude to all panelists, all presenters for trusting this platform to present your scholarly work. I wish you all a successful deliberation. Saying this, I would like to invite Dr. Sisay Sirgu, an academic and research vice provost at St. Paul Hospital Millennium Medical College, to deliver a keynote address and officially open the symposium. Thank you.
Dear colleagues, partners, and reproductive health community, it is with great pleasure that I welcome you all to the third Reproductive Health Symposium organized by St. Paul Hospital Millennium Medical College in collaboration with St. Paul's Institute for Reproductive Health and Rights. I would like to acknowledge the team who has adapted to a new way of working and organized this event despite several challenges. As already described, the theme of this year's symposium is reproductive health care provision amid COVID-19 pandemic, lessons learned, and the way forward. As an academic and research vice provost of a college with the largest maternity service in the country, I witnessed the sexual and reproductive health challenge through the course of the pandemic. I also observed the resilience of the healthcare professionals to provide quality healthcare services while fighting the pandemic. The challenge also introduced a new way of thinking, new technologies, and innovations that will continue to be used post-pandemic. The symposium hopefully shares an insight into recent research and innovative approach, as well as programmatic and policy perspective that were employed during this challenging time. I have no doubt that this symposium will share new research findings and programmatic experiences that will shed light on and provide experiences for the reproductive health community across the nation and the region. I want to express my deep appreciation to St. Paul's Institute for Reproductive Health and Rights staff and management team who have been supporting the college in our effort in ensuring quality SRHR service and reducing maternal mortality through increasing access to reproductive health services. It is my utmost hope that the collaboration will continue as we are setting the same vision of ensuring access and quality SRHR services in the nation and beyond. I also want to thank the Department of Obstetrics and Gynecology, the Research Directorate Office, and the Department of Public Health of our college for their collective effort for the successful organization of the symposium. Finally, I would like to convey my heartfelt appreciation for the panelists, presenters, moderators, and participants of the symposium. I wish you a happy and successful deliberation. Thank you.
I would like to thank Dr. Sisai Sirgu for the keynote address. Before going to the next session, which is going to be the panel discussion, I would like to take a moment to thank our sponsors. Our gold sponsors are Center for International Reproductive Health Training, in Gender Health, and the David and Lucille Packard Foundation. And our silver sponsor is IPAS Ethiopia. We thank all of them for their generous support to make this symposium a reality, and also for their work in improving the lives of women and girls here in the country and elsewhere. So saying this, I would like to introduce the panel discussion. So the panel discussion is going to be on reproductive health care provision amid COVID-19 pandemic, lessons learned and the way forward. So the panel discussion is going to be moderated by Dr. Solomon Worku. So Dr. Solomon Worku is a graduate of medicine in master's degree in international public health and fellow of medical education with 19 years of experience in academia, clinical practice, public health program, health profession, education, and human resource for health policies. He has also worked in, at various international NGOs in different capacities, including senior training advisor, program director for continuing medical education, and director for medical education training. Currently, he is serving as a technical director of the Center for International Reproductive Health Training. He is a senior advisor for the Ministry of Health on issues related to health workforce education and training. Dr. Solomon is an adjunct professor and teaches reproductive health at master's level public health programs in various institutions. So I would like to welcome Dr. Solomon Worku to chair the panel discussion. Dr. Solomon.
Thank you, Dr. Makti. I'm honored to chair this very important symposium. So next would be, I'm going to call the panels to the podium. Ms. Zamzam, Dr. Maktas, Dr. Bethel, and Mascara. The Sphere Symposium on Sexual Reproductive Health amid COVID-19 pandemic, what lessons can be drawn? So we have 4 speakers in the panel representing different institutions. I'll introduce each one. The first up there is Zamzam. She is the National Maternal Health Program Coordinator at the Ministry of Health. She would be talking on the Ministry of Health effort to ensure SRH amid the COVID pandemic. Next, sitting to Ms. Zamzam is Dr. Maktas. She is the current ISOC president. She speaks on the professional societies and professional associations' role in addressing SRH services during the pandemic. Third from the right is Mascara. She is the Associate Project Director for Right-Based Approach at the Gender Health Ethiopia. She would speak on how gender-based violence response is like during the pandemic. Right next to me is Dr. Betel. Dr. Betel is a faculty at St. Paul. She is an OB gynecologist. She would tell us her institution experience on running SRH training during the pandemic. So each one of the panelists are going to have 5 minutes to do a presentation, and we'll be having a second round question sessions as well. So I would invite them to talk on the role of ministry on how you deal with SRH issues during the pandemic. Ms. Zamzam, please.
Okay, thank you all. Also, thank you for this specific to the RH conference. Just to clarify that at the beginning of the pandemic, the Ministry of Health is just start from the sensing the global and the national issues. And then there is an establishment of the national task force, as well as cascading that task force at each level. And then there is a preparation by coordinating with the different stakeholders, that is from the stakeholders from the regions, as well as from partner organizations, different sectors like water and energy, as well as from the industry side for the production of the soap and other related issues. As well, there is information which is to collect information from the lower level, what the lower level start the service delivery point it looks like. So after that, there is this task force is developing checklist and go down to the service delivery point in different region and assess the situation specifically for all services, especially to the essential health service related with RMNSH, that's related with reproductive health. After that, that team is come back and just seeing the situation as forming the summary, what the regions it looks like, and just develop action plan and enter to that specific area to fill the gap. And then there is a assignment of healthcare providers in different regions to translate what the COVID-19 pandemic looks like. There is a development of certain messages for specific with a local language. And there is a preparation area, how especially in the border side, the in and out of there is in and out of the peoples, which is maybe to screen that border side. And there is just developing isolation areas for that, specifically those from outside to enter to the border of Ethiopia. After that, this task force is following with a region every week. Specifically, this SRH issue is very sensitive. We are not just protecting, giving the service, whatever the case, whatever the emergency situation, there is a need, the delivery, we cannot stop the delivery service, family planning service, abortion, and other like child health, immunization, and so on. So to do that, there is a document developed about the non-COVID essential health service during COVID-19, how to manage each cases specific for the delivery and labor and delivery, child immunization, abortion, and so all these cases are managed as a routine cases by using a preventive mechanism, especially with IPCs, this infection prevention and control, by using this all and availing. The main issue which we have seen during that time is the awareness. The very challenging one is awareness. The people consider once which is acquired a COVID, they may die, consider immediately. So to avert that situation, there is one national communication strategy for the response of COVID. That communication strategy how the national level it looks like and how to deliver communication to the larger community, especially related with awareness, especially with psychosocial issues, because people are stigmatized. The one which is when in one house, if someone is acquiring a COVID, the people are discriminate or stigmatize that house. So to do that, there is a lot of things done. The other issue is related with information, delivering information to the larger daily number of the cases, which number of cases is just recovered, as well as dead, and what numbers of the cases are under intensive care unit. This is also one of the strategies through television, radio, social media, and even the call like 952 and 8835, I think, if I not missed it. So the other issue which what we done is that there is a resource mobilization issues, because there is a travel from in and out, especially for those who come to our countries. There is an isolation center, and some hospitals are closed for the treatment and the isolation center. This is also one of the big challenge at that time. The clients are moving here and there to get the service, a very challenging one. The other issue is even the awareness of the healthcare providers and awareness of the community is a very challenging one. The community is considering that healthcare providers, maybe because of seeing a number of clients, they consider us that healthcare providers is transmitting the COVID-19. Even the healthcare provider side, they fear of just misunderstanding, and there is a fear from just seeing a number of clients maybe acquire that issue. So to mitigate all this, there is a national communication strategy. Documents are developed in different ways to mitigate that all issues. The other, how to prevent, the prevention strategy and so on, will be passed through that. The other very important issue is just seeing, communicating with and seeing the environment, the global issues, how to there is a prevention mechanism, even whatever the prevention is, what will be the next step? The next step will be we try to introduce the new vaccine, which is found in a global market, like some companies like COVAX, communicating with the COVAX and secure some number of antigens by seeing the one which is maybe exposed for the disease, especially for healthcare workers, by consider teachers and even the drivers and the one which has frequent contact with the population, by counting that, and the age factor and the comorbidities. By considering this, they did the proportion and requesting the COVAX by contributing some amount of money to just endorse or just not to take the introduction of the new vaccine. This also done through a national effort. The other, which maybe the number of things which is done, is that just there is a shortage of area. We're keeping the isolation and the treatment center. It's also to mitigate that. The Ministry of Health is communicating with private organizations, especially those has a large building, just to give for specifically for the COVID-19 isolation and treatment center. And the other things which was done at that time is just using as a multi-sectoral approach to contribute for that specific pandemic, to mitigate that specific pandemic as COVID-19. So there is a number of documents like non-essential, non-COVID essential health service. The other issue, communication strategy. The other algorithm is developed, especially algorithm which is related with labor and deliveries. The one which is antenatal, how to antenatal care seeking from the community, how to prevent during the traveling after reaching the health facilities, how to protect themselves and get that specific services. The other algorithm is during labor, that is imminent labor and the one which is late labor. By identifying that, there is a way of just how to refer to specific COVID screening and treatment center. Also, the algorithm also developed at the national level and disseminated all this issue. So these are the one which is efforts done so far. nearly there is one document is developed that is an integration of COVID-19 document, especially to essential health services, because most of our hospital is delineating for COVID-19 screening and treatment center. Because of that, there is a little bit, there is a service maybe shortage of in some health facilities. So to mitigate that, that hospital starts functioning by using the IPC mechanism, and that just to initiate the service, specifically those hospital health center delineating for that specific services, how to just the way that facility initiating the service also, the way we are moving, especially with pharmacy, laboratory, and the inpatient and outpatient service, the way we providing that service, maybe keeping in that specific documents. So there is a number of documents are developed and disseminated, and there is a follow-up. There is a weekly follow-up for especially for maternal days, just the reports, perinatal days, and the service, especially with SRH, like family planning and related issues, follow up seriously by the State Minister Office. And this is what the ministry done so far. And also currently, there is a follow-up with by integrating with any supportive supervision, part of it, a COVID-19, how the service is provided, regional health bureau, how to follow up this specific, because still we are in a pandemic, how to manage that all issue. There is a follow-up with from the from the minister. The state minister is the one which is leading the program, and even the directors, the case teams, and even officers there, and at the lower level, each and every service are seeing by in coordinated manner. Thank you so much. I think finished my time.
Thank you so much. I think I had to interrupt you. Maybe if there are important things that you've missed, you probably would come up back again in the second round. Okay. So
Okay.
for interest of time, I need to stop you here. So next speaker is Dr. Makdas. You're here representing ESOG and professional association. So how was the professional association role in ensuring SRH service amid the pandemic? You've got 5 minutes.
Thank you very much, Dr. Salamon, and thank you very much for Spirit team and all the SRH community for preparing sessions like this, because we know that COVID-19 has been with us, still is continuing, and lots of lives are still lost, and we have also lost lots of our healthcare providers, especially women healthcare providers, throughout this year and the year before. So it's not an easy time, I know, and I really want to take this opportunity to thank Sphere and the whole team to still talk about the importance of making sure that we are still mitigating COVID-19 and its impact on SRH services. So saying this, I would directly go into what are the things that professional societies can play and have played in the since COVID-19 pandemic has hit our country. As Sister Zamzam just rightly said, it wasn't an easy task to mobilize everyone. And I know you still can feel that we are still in the I don't want to say in the post-COVID, because we are still in it, but we are still facing lots of challenges after having COVID-19 in our country. I remember when the first case was initially announced, and just the week before, we had a meeting at EPHI to talk with the Ministry of Health team and all professional societies coming together. What would we do when COVID-19 come to Ethiopia? So that was the main theme of the discussion. And we're trying to mobilize each other. And we were saying, who should mobilize? Should it be just one professional society? Should it be just the pharmacy side? Should it be the infectious disease side? Do we have to bring the obstetrician and gynecologists? Can we just mobilize physicians together? So that was the main question that was initially raised. This was without masks. No one was wearing a mask because COVID-19 was not in our country. And immediately within a week, I remember everything changed. Back then, I really thank God and also the administration at the ministry for taking the time to mobilize us and bring us together. So we appointed the Ethiopian Medical Association as to spearhead the physicians together in leading information around all medical doctors associated in message. And then Ethiopian Society of OBGYNs, as the president of the society, what I'm going to say is, as you know, when it comes to COVID-19, it doesn't just affect one thing. So the first thing what we did was information. The information part was the most difficult part. You remember, I'm sure if you all scroll and see your WhatsApp, Telegram, things in the first few weeks and the first days when COVID hit, everyone was having loads of publications from China, from everywhere in the world. And people were really wondering what would happen if a pregnant woman or any woman gets COVID-19. Is it going to be the same with men? Is it going to be this way? You remember, we were all even saying like males are more affected than females, so we're okay. But it didn't happen. Things changed every day. So what we did initially was trying to mobilize our team and all professionals at the ground so that we have at least a compiled information for our obstetricians and gynecologists and women healthcare providers in general. So we initially prepared a series of webinars so that we can collect all information regarding the pathogenesis, the pathology, and how to admit, how to manage cases. That was the initial step, because information we were having, I think, a pandemic of information, I would say, not only the disease. And then I remember everyone was really in shock. I want to bring it to more the physical, and you know how stressful we were. And then what we brought after we had like the first few sessions were about how is the ministry planning, how are partners planning to address this. And then the next webinar was we had the maternal and child health director with us. We had different hospital managers, and the first case of a pregnant woman was admitted to Yaka Kotabe Hospital. And I remember we were all in shock. We wanted to know what was the outcome. Sadly, we lost the first pregnant woman. And that was another shock for us. So we wanted to know, is the management of the case the same when it comes to obstetrics and pregnant women? Is it going to be the same with other countries? We have our own genetics. We have our own things. Is it going to be the same? So I remember when all OBGYNs were together, it was more than 100 OBGYNs who rolled into the webinar, and we were discussing the case. What should we do? Is it going to be the same? So information and coming together, trying to know things from the root was the first thing that we did together. And we're still learning, because if you go to the webpage of ESOG, we still have a repertory system that updates any updates or any publications that are coming out about COVID-19 and pregnant women. Initially it was more around pregnant women, but now we are even seeing like the gynecology complications, the other things coming, and vaccination related things also arise. So the second thing that we were trying to address was school closure. Remember, when COVID-19 hit, it was really a big shock, and we didn't know how to continue the other school-related issues. I'm sure my colleague, Dr. Beitel, is going to address lots of it. So I'm going to just say that we were asking each other if essential services are going to continue, and the essential services, including women healthcare services, we talked and we worked with partners and Ministry of Health, and we said that essential services like family planning, delivery, we can never stop it. So how can we really continue the service, make sure that we're protecting just not the woman, but also the providers? That was the major issue that we were trying to see. And the other thing was, as you know, different informations were coming around, increase in GBV, which my colleague Masarat is going to address. I'm not going to go in detail, but we were really at the front line. We know that our healthcare providers, especially OBGYNs, should not shy away, and they should continue to give the services as it is an essential service. The delivery service, you know, it doesn't stop, but the other essential services like family planning, safe abortion care, other OBGYN services, the emergency one shouldn't stop. And I really want to take this opportunity to thank all our members and all other women healthcare providers, because they were at the front and they didn't stop the services. There were some like hiccups at the beginning, but we managed and we're still here. And the other one is about making sure that PPEs are addressing, and we don't leave our healthcare providers, particularly the women healthcare providers, at the front, because those who were going to the COVID direct diagnosed cases were more protected than those who are at the front line, like the outpatient service, the antenatal care, the delivery service areas. So we were pushing and we were discussing and we were making sure that our providers, our members, are protecting themselves when they were caring for others. It is not an easy task, but that was one of the things that we tried to address. And as an OBGYN society, we provided around 300 delivery kits and some OR equipments to different facilities. Certain hospitals were targeted. We gave as much as we had because, you know, it was all something that we raised from our members. We had around 100 health centers that got the PPE coverage, and then that just continued. That is through the mobilization. The other big pillar was the advocacy. I'm going to wind up afterwards because I can come back after the discussion, was advocacy, media communication, unless we have the healthcare providers, the women healthcare providers, to come out and say that essential services are not disrupted. This is the services that the woman will get. And we were going out and saying, if a woman experiences these symptoms, they should come and visit the health facilities, were some of the things that we did. And we made sure that our members were at the front line in different regions to address any questions that are coming from women and girls. So supply chain management, visiting different regions were some of the things that we did. So these are some of the things that we did. I just want to revert back to you if you have any further questions. Thank you very much.
Thank you so much, Dr. Muktas. Ms. Karam, we know that there are lots of evidence out there that during the pandemic, gender-based violence is at its highest. How was the situation like in this country, and how was your response towards, you know, gender-based violence during the pandemic? How did you address it? You've got 5 minutes again.
Thank you, Dr. Salamon, and I would like to thank all the organizers for this opportunity. So I will start by talking about the challenges related to gender-based violence during the pandemic. So though there was no like lockdown for Ethiopia, the restriction, the physical distancing, the school closure imposed to the reduction or the minimization of the pandemic increased the risk of women and girls to face or experience gender-based violence, especially by close family members or those who are close to them. So we have seen like different data from the international community. The United Nations reported like there was 25% of increase gender-based violence during the pandemic. But though there is limited data for Ethiopia, the Ministry of Women, Children and Youth reported that there is like 25 to 30% of increased rate of confirmed cases of rape, domestic violence and sexual assault during the first few months of the pandemic. And further, survivors and those at risk of gender-based violence were restricted, or they were fearing like to seek information service from nearby healthcare facility or legal enforcement bodies because of their fear of COVID-19 and other restrictions. So to come to the approach used by my organization in gender health, so the challenge and other issues required locally tailored, comprehensive and multi-sectoral involvement. So we collaborated with the Ministry of Women, Children and Youth and the Ministry of Health so that we can redesign our project activities and tailor our approach to respond to the needs of the survivors in order to protect and support survivors of gender-based violence. What we did was some of the approaches were like, the first thing we did was media-based intervention so that we can create awareness to the public that essential services are continued to be provided despite the pandemic, and the referral systems available in the systems. And we have also worked with health facilities so that we can ensure there is readiness at health facilities to provide counseling and medical management of gender-based violence. We have also worked with police commission and other partners so that we can create like helpline specifically to receive and support survivors through existing call centers. And other initiatives we worked on includes like a community-based intervention. It is a pilot intervention specifically implemented here in Addis Ababa. So we piloted gender-based violence prevention committee So this committee works at community level to provide information to the community, the referral systems, and to identify like any cases of gender-based violence happening within their warada or district, and refer to the health facilities and to the legal systems. We have also worked on advocacy and to ensure that there is a continued dialogue in our systems so that we can prioritize sexual and reproductive health and gender-based violence response efforts, and to integrate gender lens within our work. In addition to that, we have also ensured like the availability of personal protective equipments and menstrual hygiene products, specifically at health facilities and at centers which were providing COVID-19 treatment and service. The interventions like were effective, like the media intervention were effective in reinforcing messages to the public that essential services are continuing despite the response of COVID-19, and reassuring the public that we are providing service beyond that. And there was improvement in service readiness on health response to gender-based violence. For the future, I believe gender-based violence response, like it requires comprehensive and collaborative approach, and it needs like multi-sectoral involvement, and a response should be like integrated and to address those issues at agency level, structure, and relation level, so that we can ensure that we are comprehensively addressing the concerns and challenges. Thank you.
Thank you so much, Ms. Kara. Dr. Betal, your institution is a training center as well. So we'd like to hear from you how your institution has run different trainings and workshops on reproductive health during the pandemic.
Thank you, Dr. Solomon, and thank you, Spear, for the invitation. So I will be talking about running a SRH program training while we were in the middle of the pandemic. So there are many challenges that we have faced. As you know, medical trainings are basically trainings that are given during giving services, which are directly associated with medical service. So there were significant challenges during this time. So if the trainees are not basically exposed for those challenges or for those clinical services, you can imagine how much there is a direct impact on the learning teaching process. So it's not only the knowledge, the skill and the experience of the outgoing graduating medical students and residents are going to be affected. So as you can remember, majority of the medical schools for the undergraduate programs were closed, but the postgraduate program should continue because those people are still the major stakeholder while giving the clinical services in each and every teaching institutions. So the figures that I'm going to tell you, or the evidences that I'm going to tell you now, are based on the data which were collected in 12 SRH running program institutions that has collected, and some of the mitigations that we have done at St. Paul. So there was somewhat decrease in high risk pregnant women and ANC following women. So these women, there was somewhat significant amount of decline during the first weeks of the pandemic, but finally it was reversed. This was reversed because we started communicating these patients and finally calling them back to the hospitals. There was a significant decrease in the cold cases or gynecologic patients and minor procedures, which was really difficult to engage the trainees during these times. And there was a slight decrement in patients who came for family planning services. And fortunate or unfortunately, there was a significant increase in emergency cases, both gynecologic and obstetric cases. And when we see this back, the reason where majority of the health center and some of the district hospitals which were used to cover these activities were turned into a COVID treatment center, and there was significant surge of patients to the training centers. And initially there was a decline in the family planning service. Finally, the safe abortion care and family planning service increases After you heard about the data of the gender-based violence, so these patients turned out to come to these institutions. While serving all these emergency cases, as it has been stated earlier, there was a significant gap of personal protective equipment. And totally, we were not considered as those people who were exposed. So specifically in our department, what we did was we contributed money from each one of us and prepared a scrub for our residents. So because they were the one who were working the front liner. And the significant decrease in skill and exposure and clinical service was in infertility patients. There was a significant decline during the first 3 months of the pandemic. And when we come to the teaching activities, direct teaching activities in the medical services, there was nearly a complete interruption in majority of the centers in didactic lectures, demonstrations and medical procedures, skill labs, seminars, management session, teaching rounds, and attachment to other departments were significantly compromised. And these things were tried to be compensated in different mechanisms. So some of the compensations that we have done in our department, so the face-to-face teaching techniques were completely changed to virtual setup. So we turned the case presentations, the seminar management sessions, and other tutorials through virtual setup, so that in this type, it was good. It was a nice experience, but there was a significant challenge because our internet connectivity was difficult in other areas and the infrastructure was not well developed. And morning sessions, it was decided to make it in a small group people, so that we are not going to expose majority of our faculties and residents. So those who were on duties and those who are going to receive the duties are the one who were going to attend this morning sessions. So elective surgeries were started basically late May and June in our setup. And so what we did was, as the previous time, we don't admit majority of the patients for elective surgeries. Only those who are going to be done the next day are going to be admitted. So they are going to be screened and we will make sure that they are negative for COVID. And then we also decreased the number of trainees within the OR. So the exposure and the skill transfer can be decreased, but that was the only option that we had to safeguard the patient, ourselves, and the other OR staff. And then there was some reallocation. So trying to redistribute the residents so that their exposure could be somewhat fair for all of them. So in the future, what the recommendations are the strategic, we should have a strategic plan when we have such a crisis. So what are we going to do when we are in the middle of a crisis? So this should also be done for a teaching institutions. What are we going to do when we have such types of pandemics? And we should have alternative mode of teaching, like we should prepare rotations which are going to be covering the service, the research activities, and then the training, so that those residents who are, or medical students who are active in the clinical service, they will stay for 1 week or 2 weeks in the clinical service. The remaining, they should focus on the other teaching programs and the research activities. So we can also, for the practical sessions, we can also use surgical videos and 3D atlases, so that we cannot take every student to the patient, but we can take them to these videos or even to the cadavers, so that these types of modality of teaching should be prepared. Other web-based simulations and virtual learnings should be encouraged. I think this was a good challenge, even if we have faced a lot, but it has shown us the way forward, how we can mitigate such things. Thank you, Dr. Simon.
Thank you, Dr. Beta. So we'll be having a second round. Quick one question. I'll be also summarizing what has been told by the speakers. Zamzam, the ministry's response to those points that were critical were you happen to create a national task force, engaging different stakeholders. You come up with different guidelines and recommendations and sort of policy documents. You've also mentioned, you succeeded in delivering information to the public using different media platforms. You also mobilized a lot of resources to mitigate the pandemic. You are also engaged in availing vaccines, community mobilization, engaging the private health sector as well. So all in all, there seems that the ministry had a lot of efforts to mitigate the pandemic so that SRA services were not affected. How successful were you? This is one last question for you. In terms of, having all these efforts going on, having the ministry, trying to do everything, how successful were you in terms of preventing SRH services will not be affected? So do you believe that SRH services were not that much affected because of your efforts? Over to you.
Okay. Thank you. Just first of all, I would like to mention certain challenges which related with the COVID, and then I come back to the success of just our program interventions. So the challenge what we faced at that time is a shortage of medical equipment and supplies. Also, there is awareness. I mentioned it before. The other shortage like personal protective equipment and so on. The other which what we faced at that time was the maternity waiting home were closed at that time. So the mothers are delivered at home. Because of that, we lost even immediately within 2 to 3 months, we lost a number of mothers just home delivery, and because of postpartum hemorrhage, we lose a number of mothers. So when I come back to the success, we can just, as I think that we were successful, still we are just on the pandemic, we are strengthening what we are introduced or what we are started, just intervene all the problems. So the first 1 or 2 months of the during the pandemic in terms of our country, we are just when we see observe the indicators, the indicator is going down, the antenatal care, delivery, just this family planning coverage, and everything is reducing the first 2 months. After we are mitigating, or after introduction of a number of documents, just creating a community awareness and introduction and availability, increasing the availability of commodities, personal protective equipment, and so on. After that, there is a start to raise the essential health services. So still, just even if we are just intervene in number of interventions, there is also there is some gap. But if we are continuing on the previous one, we missed a number of cases. That means we are fearing the one which is seeing at Congo, I think 2040, because of Ebola. The number of cases the days are increasing because of just not because of the disease, rather because of just not seeking the essential health services. We are losing they are losing the Congos. Just taking the experience from the Congo, we are trying to mitigate and using a number of interventions to save the life of the mothers and newborns. As well, we try to just continue in a good way the essential health services. So we were successful, I think, and we try to just continue with strengthen that intervention is what we designed it before.
Thank you so much, Dr. Zamzam. Dr. Makdas, I think you've mentioned that professional societies and associations have got lots of engagement in terms of mitigating, ensuring SRE services during the pandemic. Some of the points that you've mentioned were, there is a huge mobilization within associations and societies. You've been delivering information to the public. You also try to, particularly initially, you're more focused on, preventing particularly pregnant women. You were also, the societies, associations were active in terms of, advising the ministry what measures need to be taken during schools. You've also addressed some issues about gender-based violence as society. You are in the front line. And you've also participated in availing supplies and equipments that are helpful, the PPE equipment for the pandemic. What could be this one important lesson that can be drawn, professional association need to do in the future in terms of occurrence of pandemic? How should association need to be ready? Can we draw any lesson from this?
Thank you very much, Dr. Salamoon. I think lessons are always good, and I agree with you. We've seen that we were not that much prepared. We've never been prepared for a pandemic, not even for outbreaks. So essential services and obstetric services and gynecologic services in general need always preparation. We've seen that our adaptation system, we have adopted a lot. We have changed it, we are able to change, but we have to start mitigating ahead of time. What would happen if we're going to have a third surge, a fourth surge? What if this is going to continue? You probably have seen that in September 2021 in the World Economic Forum, they've said that 39 years we have went back, by the way. Whatever we have accomplished in the past few years, we've already went back 39 years. So whatever is achieved through gender equality, whatever is achieved through like women empowerment, gender equality, whatever, all of the things that our society is always standing for like the safe motherhood, all the initiatives that we have taken, we have already went back. So, but there is a way to bounce back. We have to start preparing, and we have to make sure that we're still always protecting our frontline workers when we are protecting others. Okay, unless you protect yourself, you cannot work for others. So the lesson we have to draw is we have to start generating evidences. We haven't even generated evidences as much. I'm so ashamed to say that we are still lacking the real evidences of what is exactly going on with pregnant women and girls and the effects of COVID in our country. So we have to start with not just mitigating, but still learn that we are failing. We have to start generating evidences, use these evidences, share evidences as much as possible. We're not in an era to say that we have to wait this, we have to wait for that person to do it. We all have a role, and we all have to play a role when it comes to pandemics or whenever it gets to women healthcare services. And the other thing that we have to make sure and use in the future is information. Because whenever pandemics are coming, there is high tendencies as misinformations and like measles, and the use of different opportunities like that, and to use that to take back gender related or women health related issues some years back is usually used as an opportunity. So the lesson we have to take is we don't have to sit and wait for others to be on our table. We have to be in the table. We have to give information. We have to make sure that false generated data are not coming out when it comes to essential services. So making sure that essential services are not taken for granted, and actively working on generating data, informing policy, working on technical guidelines, and disseminating and updating ourselves is very important. Thank you very much. And the other one thing that I don't want to leave is in making sure that we are not leaving anyone behind. Most of our informations, most of the things that we were generating were not inclusive of everyone. One thing that I want to give is, are we really including women with disabilities? Are we including everyone in our setup? Were we really there to say that we have addressed everyone's need? People who are having some mental problems. Are we really addressing the psychological demands of our providers? Is something that we have to learn and make sure that we address it every day. There is a lot we have to learn, and time is not allowing, but we have to learn from each other. And this is one thing I want to say, hold each other when it comes to pandemics, and make sure that we are not leaving no one behind. Thank you very much.
Thank you so much, Dr. Makdas. Maskara, like it is sad to hear, just like any other country, Ethiopia, women and girls are in this country were suffering also gender-based violence because of the pandemic. And you've noticed that there is an increased number of cases. It's about 25% you've mentioned. So it was serious, but you seem to be doing a lot of things, including your collaboration with the Ministry of Health, engaging the media, particularly to raise awareness among the public that women are in gender because they stay at home, because they're not working. You do a lot of referral. You've been also working with facilities, right? Giving them whatever support they need, including the management of gender-based violence. You also have been collaborating with the community, particularly to not only to raise the awareness, but also to do more of reporting of cases. You also mentioned that you've been doing a lot of advocacy works, particularly to enhance the dialogue on discourses among the community. I know doing this, gender-based violence is not new, but the pandemic even make it worse. So how are you going to sustain that? We're still in the pandemic. We don't know when this is going to end. How are you going to sustain this? This seems to be a lot of engagement. Would there any way that you still can continue, working whatever you're doing right now, so that you would sustain this, so that the pandemic will never affect our girls? Because it looks that it is increasing given the demand for other SRA services, particularly abortion care services as well. So how are you going to sustain this?
Thank you again, Dr. Solomon. So we are working with the system like the Ministry of Women, Youth and Children in Health. Thank you. So we are working with the institutions and system at Ministry of Health and the Ministry of Women, Children and Youth, so that we can sustain the approaches and changes that or initiatives that we are introducing. The first thing we did was since there is a gap in generating evidence and data, it's work in progress, but we are working to create, there is a reporting system from the community to the institutions, so that there will be continued dialogue or asking the progress that's happening within the system. So we are also working to create referral pathways from the community, so that will help to sustain the approach and the initiatives that we are working through the projects we are implementing. The other thing is through the advocacy sessions, it's also a work in progress, but we are questioning the laws, like the government policies or the structures that are in place that needs to be changed or improved related to sexual reproductive health and gender-based in response to gender-based violence. I think that's a work in progress, but we are working to sustain the approach and initiatives into the systems.
Thank you so much, Mascara. Dr. Betel, you've said that COVID has seriously impacted overall the health profession training, including the medical training. And the training is so much affected because of the decline and clinical services as well, because the nature of medical training is you need patients and cases to train students. You've also mentioned there were times that teaching was interrupted, but you've managed somehow to compensate, particularly the didactic learning through availing virtual platforms. You also try to decrease the number of trainees in the OR, trying to redistribute them. Overall, somehow you've managed to continue doing the training. Now, this seems a blessing in disguise. This would give us an opportunity to think out of the box and come up with some effective ways of delivering and teaching our students, particularly using technology. What would be those important, educational strategies that you have taken from this so that you would continue if the pandemic is over?
So basically, we have learned a lot from these challenges. So even if the pandemic is over, we don't have to do everything in face-to-face. I think that's the takeover message. I was thinking we had a huge number of professionals at St. Paul, but we have 31 medical schools in Ethiopia. Do they have the same amount of professionals? No, but we can use these all professionals virtually to teach the other institutions. But finally, we are going to give them the same types of national exams in which they are not exposed at all. So this was a big lesson learned from this challenge. So I think some of the things that we can do virtually, they should still go virtual. So the government has planned in 2025, we are going to go all digital. So we should be planned and prepared for that. Are we ready? So what's the medical training is going to be? Are we going to take it everything like the previous traditional methods? I don't think so. Even the upcoming generations, they are going more digital than we are. Previously, where we are taught in each cadaver anatomy, now people, they are learning from 3D games and 3D videos. So I think now is the time to go digital and to approach or to have more technology-oriented medical professionals. And I think that was the best things that happened during this pandemic.
Thank you so much, Dr. Bethel. I think we've got like 15 minutes before we break for tea. I'd like to thank all the panelists first, but before I send them off, I would give the chance to participants here or virtual, if they have any question to the panelists. Like we have got 15 minutes to go. So 1, 2, 3. So you can, I'm also hoping that people would ask through virtual as well, so you can bring me the questions as well. So go ahead, number 1. So introduce yourself and then who you're directing the question for as well.
Okay, thank you. Good afternoon, everyone. I'm Aunat from St. Paul's Hospital Medical College Public Health Department. My question is not specific to anyone. You know, from today's presentation, we have heard about COVID impact on healthcare professionals, students, the community, and patients. But you know, because the 16 days of activism is approaching, I was looking for some evidences online in the scientific platforms, and it was difficult to find complete evidences about, you know, how women and girls were affected by COVID. Even about GBV, we have heard about, you know, there is an increase in GBV. We have heard about, you know, there are different impacts, but the information part was missing. So is there any systemic initiative to understand how COVID has affected specifically, if it has a gendered impact, not only among patients in the community, but also among healthcare professionals? And in my opinion, one of the gaps we have understand because of COVID is our lack of documentation. You know, I have observed there were specific initiatives by individuals, group of researchers, group of healthcare providers, but all that efforts are not available. So if we want to advocate for, you know, improved life for women and girls, we have to make this information available. And advocacy comes from different actions. It's not only from someone working within the government or within the institution. It can come from, you know, someone from the outside who have come to, you know, the issue, who have drawn its attention to the issue, you know, in different forms, including researchers, funders, and so on. So what would be the future of, you know, making information available to the general public, especially to the scientific community?
Thank you so much. That's a wonderful question. So let's take every question and I'll get back to you.
Good afternoon. I am Ababa Kabede from the Consortium of Reproductive Health Associations, an umbrella of 77 international and local CSOs. Actually, one is a question, but the others are just like a reflection on what the presenters have said, and I really appreciate the presenters and the organizers as well. My first question is, we really observed a huge gap in terms of generating evidences. What was really the impact? In fact, it's really, it's not time to say impact, but effect of COVID on SRHR services. I know that the study was done by EPH and at Addis Ababa University School of Medicine on the effect of COVID on the general health services, but not specifically on SRHR. After looking this gap, we're trying to to do some kind of assessment on the effect of COVID on SRHR on our side, but we need to have some such kind of, sharing the findings of different researchers if there are. So one huge gap that we observed is that, and if there is any evidence generated or researches, I think this is really a good opportunity to share among ourselves. The second opinion, my opinion is on, as Dr. Magda said, since we are living with COVID, we need to really strengthen our partnership, coordination among the civil societies, the government, and the developmental partners, so that we could really be able to make a difference in responding to COVID-19. And we don't see, such kind of strong cooperation and networking or such kind of, partnership, so that, we see fragmented kind of activities here and there, and there is no ways of, documenting the best practices, as my colleague said earlier, and we need to look at that as well. The other one is, especially during COVID, schools were closed, and we really missed the potential change agents like students because they were staying at home. So that was not really easy, but that gives us some opportunities to look for different ways of reaching these young people, so that they could really disseminate the information to their families, to their communities, like the IT, the information technology, because the young people are very much interested to use that technology. And I am really happy to see what efforts have been done so far in terms of, reaching these young people. The other one is on the economically vulnerable group of people, like female sex workers and young people living with HIV. It was really very much challenged during COVID, especially at the beginning. And even some civil societies were diverting some of portion of their resources to provide food services and other non-food items. So this is also need to be considered as well. Thank you very much.
Thank you so much. Third person.
Okay, thank you. My name is Mulugeta from Debre Tabor University. Actually, I sent it through virtual, but it needs some clarification. Thank you, the panelists, for your nice discussion and presentation, and Dr. Solomon for your chair. And my question is for Maskar. Currently, I'm just in Jimma for educational purpose, and there was a debate on addressing gender-based violence in our community, a debate on the approach of addressing the gender-based violence. We have been facing different gender-based violence in different settings and situations, and different strategies and policies in our country are guided by right-based approach. And in our situation, it needs some sort of modification, and we thought that need-based approach is a better approach. What do you think about this, and what do you say about this? And the next is for Zamzam and Dr. Bete. You mentioned that there was a decline in service, especially in delivery service in your institutions, and you tried your best just to just serve those who came to you at the pandemic time, and you are already serving them. But there are women who are being delivered in their home. I was expecting a public health professional to be participated in this panel. How did you what was the approach, and how did you manage those women who have been delivered at home during the pandemic due to fear of COVID-19? Thank you.
Thank you so much, Magit. I think the panelists could react to the questions, right? There's no pattern. Anybody can proceed with the question. Would like to go first.
Okay, thank you very much. I would start with Dr. Unat's question about the effect of the pandemic on women and girls and the evidences, which is cross-cutting. I think everyone is already raising that issue. It's very important, as you said, it is really true. We're lacking, there are individual research, as you've said, but there are also institutional research that are still collecting data. We're not sharing it. That was what I was really wanting to address earlier. We have to start sharing evidences as much as possible to the public and to make it really like shareable. As much use also local journals, because this is our data. We want it to be used in here. Sometimes even some of the data that are generated in here are published somewhere that we're not consuming it. So there are different things that were initially published, and even this time when it comes to its impact, like the impact on the recent Guttmacher report that was just released this month on this month, November 2021, was talking about the impact of COVID-19, particularly on adolescents in Ethiopia. So that data would be a very good data, but I was really trying to see how they really do the real research related issues. But it has some year, like a 1 year cross-sectional data, they tried to generate that data. And some of the numbers that were raised in there are really significant. I want to raise it to the public so that we know that there are evidences coming. So for example, there are around 20,738 adolescents who had unmet need for contraception in a year period when they analyzed through the country. And there were like 8,884 unintended pregnancies that occurred in a year. This is just for adolescents affected directly by the pandemic. And 14 adolescent maternal deaths were reported in the countrywide studies that they had. This probably is still like the sampling and everything was not clearly put. And the other thing was 438 adolescent women were treated with major obstetric complications directly in relation to the direct and indirect impacts of COVID-19. I'm sure these are just the tip of the iceberg, because one of the one data that we have published from the St. Paul's even was trying to check what was the impacts of COVID-19 as compared to just the year before it hit. So we tried to compare the number of family planning used, the number of abortion used, the number of other procedures, just comparing similar months a year before. And it's still, as you said, still the tip of the iceberg. We need a multi-center, cross-sectional, every multi-region, and even trying to have at least the whole teaching hospitals can also give us a very good way of seeing it. And a community level data is very important so that we don't even miss those women who are giving birth at an institutional level. Of course, there are challenges that are coming. COVID was new. We're still learning, but it has really shown us that we're still fragile. We need a lot of work around data generation and sharing our evidence, using the evidence. So there are also some data that are still being done by different partners, as Abeba was really sharing, because some partners were trying to generate what were their impacts, what has been the things that they have faced in commodities, in different things that haven't been published. So as it has been stated by Ababa too, we have to have a coordinated efforts, use our evidence, and reduce our fragmentation. And the other issue that was raised by Ababa, which was talking about rebudgeting and its effect, we haven't still addressed it. This is very important. We have rebudgeted most of our budgets that was allocated for some other services. When COVID hit, every partner institutions, I'm sure, have rebudgeted their budget, and they were forced to use all that for PPE, for other things. That impact is something that contributes to going back for some years in all the services that we wanted to gain per year. And I would give the rights-based and the need-based approach to Maskaram, but if it comes to back to me, I will raise it again. So thank you very much.
Thank you. Just maybe one question or two is raised for me. The first issue may be related with evidences. We are working different schools, that's universities, working on the evidence generation, specifically those universities working on the medical learning and teaching institutes. As just everybody knows, women are the frontliner which is affected by this disease because the women are the caretaker of the household. Even if the breadwinner is a man and go here and there may be infected, the chance to be infected, but the caretaker are the woman. So it's a frontliner affected by this disease. There are when we see and related with healthcare provider, still specifically in the maternity area, most of the service givers are when it came to the lower level, the primary healthcare unit, especially health center level, on the maternity and labor and delivery unit, especially there is a woman healthcare provider there. So it's affected by this disease. So as an evidence, we need to generate evidence. Just still there is an evidence, but we need more evidences to just mitigate this, not only this pandemic, also in the future, we don't know what types of emergency situation or the like pandemic like COVID-19 may be raised. So to mitigate this, Minister of Health has the design all our national policies like guideline, the protocols and everything to accommodate emergency mitigation strategies. So on the other way around, the thing is we try to observe from or what we learn from the COVID is that our health system is not resilient as we are thinking, even not Ethiopia, the other like UK and America, how to become checked with this pandemic. So it learns a lot from this. As a minister of as a health sector, we try to secure some budget in the future, especially by just designing like a trust fund, something for emergency situation. The other points which is raised for me is that declining the indicators related with SRH, like antenatal care, delivery, safe abortion care services, and so on. So family planning also. So to raise up these services after the assessment of even the state minister, which coordinating with the directors and respective case teams, he observed go the service delivery point and the gate. There is an assessment which is there's a fear of the service provider and as well as the clients. In between there is a bridge to there is a gap to bridge that problem. There is a number of documents are developed like national communication strategy, how to update the populations and how to prevent, and also there is the just awareness raising and the mitigation strategy for the just information which is misinformation about the COVID-19. Also there is a psychosocial part. So by doing this and by using interventions, like there is a challenge during the COVID pandemic era, that means specifically related with the bed accommodations, just the lack of bed, not using maternity waiting home. And by seeing this, there is different documents are generated and aware and enter to the service area. After that March and the end of April, things become somewhat it become resolved. Then we are not stopping here. Better to follow up even every service and every program when we are reviewing the parallelly, like what you call it, mainstreaming, like we can say that integrating COVID in every part of our daily activities. So by doing this, I think things become more or less resolved. Still, we are in a pandemic. We try to mitigate by keeping everything, just by integrating every service with COVID-19 lens. Thank you so much.
Thank you again. From my experience, I believe that our approach should be not only need-based, but it should also be like locally tailored to the needs of women and girls. But I just want to summarize, like in terms of addressing gender-based violence, our approach should include like 3 domains. The first thing is ensuring issues at agency level, like ensuring the life skills and building the knowledge, the SRH knowledge of women and girls. The second is at structure level. So it includes like working at policy and laws level. It also includes building the capacity of service providers. So this is not only include the healthcare professionals, but all professionals who provide service to women and girls. We also have to challenge like the social norm and the institutional practice that we have currently going on, so that we can like to have sustained change. And we also have to work at relation level, because one of the challenge for gender-based violence is the power dynamics and the relations with intimate partners and family members. So we have to ensure that our approaches are also included these three domains while designing interventions. Thank you.
Okay, thank you. So I can speak for my institution, but our delivery didn't decrease, by the way, it really increased, because majority of the health centers we are attending the normal deliveries, they were closed or they were assigned as an isolation center, so that those patients were coming to us. But those patients who were on follow-up, who disappeared, so we had our chart, they were registered and they had a phone number on that. So we called them back to come back to the hospital, and they were rearranged so that they were not be crowding for them. So that was the thing what we have done.
Thank you so much. Okay, one last point.
Just one last point to add into the need and the rights-based approach. This is very important for me and all of us who are working on women healthcare, because this is not just for gender-based violence, but just in care in general for women healthcare. The first thing that comes is information, the knowledge, which as Karam has already addressed. When people know their right to information, when we are really giving them the real need of some of the things that they need around information, then the rights come. So then the rights to information will change everything, because the need will arise. So if we want to approach with need-based, if people don't have the information, if they don't know what they would need, we're not giving them the right. So it all is around like the chicken egg dilemma. So the right to information, the right-based approach, and the need-based approach will come. When it comes to, for example, such forums like this, whom we are working on women health care, when it comes to safe abortion care, when it comes to family planning services, when we start with need-based approach, the first approach, one example is around maternal morbidity and mortality. If we're talking about decreasing maternal morbidity and mortality, because that was really a pressing need. That was a pressing need from the data, not from the woman's perspective or the user's perspective. So need can be from the data or what is coming out of the challenge, but the rights will come, like, as we know, all the rights of sexual and reproductive health services. So now, if the data are showing you that the mortality is decreasing, would you stop there? There is no need, doesn't mean that the need has stopped. The need to address their information, the need to address their reproductive health and rights will come. So need still comes. It's like I said, the egg and chick dilemma. So we have to merge both when it comes to addressing reproductive health services. Thank you very much.
Thank you so much, Dr. Maybe one last question for you before we close. As it comes through the virtual platform, a person asked, how do you see the self-care for reproductive health in COVID pandemic?
Okay.
Would you say that in 1 minute?
Yes, within 1 second. Self-care is our way forward. Self-care, not just only reproductive health services, but the day we start to measure our blood pressure and know our hypertension, whether we are hypertensive or not, we started to use self-care. So the way forward, when it comes to even addressing challenging issues as reproductive health issues, is making sure that we are enabling women and girls, and all, not just women and girls, but everyone in particular, to care for themselves, to decide for themselves. Then the self-care issue comes. So the self-care is going to be the way forward. We have a lot to do around making sure that we are, it doesn't come with nothing. It has to have enablers, and the enablers are some of the things that all of us have to work around. Enablers like information, enablers like the technology, enablers like the evidences that are generated from other places, and learning from what we can modify. Thank you. So,
Thank you so much. I think before we close, these are some key points for us to ponder. First one is, let's not forget that it's critical that we do partnership, that we come together, we align whatever we do. Number two is, let's keep on generating evidence, but it shouldn't have to stop at the level of evidence. It has to be synthesized, and that information has to be shared with everybody who's responsible. And we need to also come up with a sort of homegrown strategies. Okay, we should design our own strategies to respond to whatever problems that we're having now. And the last would be, in pandemics like this, you know, somehow we need to innovate. Like self-care could be something to consider. This is the right time for to consider self-care as well. With this, I would like to conclude, and I just want to thank all the participants, both virtual and live. Also greatly want to thank all the speakers in the panel. Give them a round of applause, and thank you, Sphere, again.
Thank you so much, Dr. Solomon and the panelists for the nice discussion. Let's have coffee break. So it will be served just outside, or the organizers will show you where it is. Before that, as we go out, let's have a group picture so that we don't miss people who joined us today. So please. from coffee break. The next sessions are going to be oral presentations. So for these oral presentations, we have 2 moderators. We are going to have 4 oral presentations. So our moderators for this session are Dr. Unat Gabrahanna and Dr. Abel Tashoma. I will introduce them briefly. Dr. Unat Gabrahanna is an assistant professor of public health and reproductive health at the Public Health Department of St. Paul's Hospital Millennium Medical College. She's an academician, researcher, and advocate of reproductive justice and equality. She has participated in several local and international researches and contributed enormously to the scientific community. So I would like to welcome Dr. Unat Gabrahanna. So the other moderator is going to be Dr. Abel Tashoma. Dr. Abel Tashoma is an assistant professor of obstetrics and gynecology. He is a graduate of Jimma University, and he did his specialty training at St. Paul Hospital Millennium Medical College. He is currently a fellow in reproductive endocrinology and infertility. He is also currently serving as a faculty at St. Paul Hospital Millennium Medical College. Please welcome Dr. Abel Tashoma as well. So you are welcome to take the chair.
So the first presenter will be Solomon Shitu. Solomon Shitu is an assistant professor at Welkite University, Department of Midwifery. He obtained his bachelor degree in midwifery and his master degree in maternity and neonatal nursing. He has 15 researches published in reputable journals, and he has 5 ongoing researches. He has 7 years of experience in clinical setting in a hospital and teaching at a university. I'll call upon Solomon Shitu to present. The title of the research is Intimate Partner Violence and Associated Factors Among Reproductive Age Women During COVID-19 Pandemic in Southern Ethiopia 2020, a community-based cross-sectional study.
Okay, thank you, Mr. Modulator, and thank you, the coordinators of this symposium to present this global social and public program of the world. So I am Solomon from Welkite University, and I will present research entitled Using Intimate Partner Violence in Associated Factors During COVID-19 in Gurage Zone. So as an outline, these are presentation outlines. So we'll deal about these all subtopics after this. So as an introduction, WHO describes intimate partner violence as physical, emotional, or sexual violence by an intimate or cohabitant. So about 35% of women worldwide have experienced this violence by their intimate. So data from Africa showed that 36% of ever partnered women experienced lifetime physical or sexual violence. The magnitude of intimate partner violence in Ethiopia is about 20 to 78%. And during COVID-19, isolation and stay-at-home measures and movement restrictions related to COVID-19 have brought women and possible perpetrators together under confine of home setting. So from all forms of violence, approximately 1.3 million people worldwide die each year. One woman dying every 3 days after the pandemic of COVID-19 quarantine. In Addis Ababa during the era of COVID at the beginning, within less than 2 months, there are about 100 girls have been raped. Most of them are by their family members. So therefore, this study was aimed to assess the magnitude and associated factors of intimate partner violence at the study area or Gurage zone. So as an objective, the general objective is to assess the magnitude and associated factors of intimate partner violence during COVID-19, and specific are the magnitude, assessing the magnitude and determining, identifying the factors associated with this intimate partner violence. This is methodology, study design, area and period. Community-based cross-sectional study was conducted in Gurage zone, southern Ethiopia, from June to 1 to 20. And it has, the zone has about 16 districts or waradas and 5 town administrations. As a source population, all reproductive age women were on source populations, and study population was those random selected reproductive age women and living within that zone for at least 6 months. As inclusion criteria, all reproductive age women living in study area and reside for more than or equal to 6 months were included. And as exclusion criteria, those participants who were seriously ill and unable to respond during the data collection were excluded from the study. Sample size determination, sample size by using single population proportion formula, using 24% of prevalence, which was done at northern part of Ethiopia, Tigray. And so the calculated sample size by adding design effect of 1.5 due to its the effect of cluster sampling and 10% of non-response rate, the total calculated sample size was 462. And from those districts and town administrations, we select two town administrations and 5 districts, and finally 2 qabeles from each district and town administration were selected, and those eligible participants and selected by using systematic random sampling was as source or as study participants. When it's the variables, as dependent variable intimate partner violence was dependent variable and independent variable socio-demographic, socio-economic, post-related factors, COVID-related factors, and decision-making power of the woman was some of independent variables. So data collection instrument and procedure. The data was collected by face-to-face interview. It was adapted from a previous study, and it was modified, and to assess the outcome variable, validated and structured questionnaire from WHO was directly adopted and just modified to local context. And to ensure quality, we used English language questionnaire prepared first, and then we translate to Amharic language and back translate to English to check its consistency. To minimize bias, the interview was done in private room with adequate confidentiality, and the questionnaire was checked for completeness before data entry. Processing and analysis, the data was coded to clean. It is entered into Wikidata 3.1 version, and it's directly exported to SPSS 24's version. And the analysis was done by computing proportions and summary statistics Then it was presented by text, frequencies, and figures. By variable and variable analysis was done for independent variables. The direction of strings was checked by using odds ratio with 95 confidence interval. The p-value less than 0.05 was declared that it was significantly associated with a dependent variable. Ethical consideration, ethical clearance was obtained from Wolkite University, and a formal letter was obtained from Wolkite University to the concerned bodies of the zone, and all study participants was informed and verbal consent was obtained before the interview. When it's the resulting discussion, socio-demographic variable, a total of 448 participants was responded with a total response rate of about 97%. Two-thirds of participants' age range was between 20 and 29. More than two-thirds of participants were rural residents, and 37% of respondents' husbands were diploma and above educational status, and 87% was married during data collection. So these were some variables, socio-demographic variables that indicates the respondents' socio-demography. So COVID-related variables, all respondents during that time, the study was done about 3 months after the pandemic. So at that moment, all respondents or participants were informed or know about the time, the pandemic, or they know about the COVID-19. Only 60% were tested for COVID-19, and those all of them were negative for COVID-19. So 30% of respondents have at least one family member tested for COVID-19. From safety precautions, 22% were apply social distancing, wear mask, and use sanitizer, and only 36% only wear mask, and 21% use sanitizer. Social support, alcohol use, and decision-making power of the woman. Almost half of the respondents' social support was medium. This social support was computed by using social support, maternity social support scale. So about 49% were medium social support, and the other 29% was low, and 21% was high. 3/4 of respondents drank alcohol at least once in their lifetime, and of those respondents, 33% of respondents were decision-making power by themselves on their day-to-day activity. This decision-making power, 33% of them decide by themselves, and about 59% of women decision-making was done by their husbands, and 3% by her family, and 5% by her husband's family. Of three characteristics, more than half of were gravid 2 and 3 from those respondents. 249 respondents were gravid at 2 and 3. The others, 31% were nulliparous. From those who had a previous history of pregnancy, nearly 3/4 had antenatal care follow-up, and 31 had history of abortion, and 30 participants had a previous history of child death. And from those who had history of 2 or more delivery, 18.9% had similar sex of their babies previously. When is the prevalence? The overall prevalence of intimate partner violence was 42.19%, and 2 months prevalence at that moment from the onset of the pandemic, and our study, the total prevalence was 14%, 14.14%. So when we see the comparable studies, the studies we are comparing the total, the lifetime prevalence of IPV. So it was in line with the study done in Tigray, Debre Marcos, in Harare region, and it was slightly higher than studies done in Tanzania and EDHS 2016 and Shirinde Selassie study. And it was lower than the studies in Southeast Oromia and Dilla town. it was due to difference in study area. The reason may be due to the difference of study area period and including the occurrence of this pandemic. Then some of the studies were done only on our urban residents or focused on specific characteristics of the population. So when we see the Venn diagram of this prevalence, 36% of reproductive women committed emotional violence and 29% sexual violence and 18.2% physical violence. That all type of violence was about 12.9%. So when it's the predictors, these variables, age, residence, husband's educational status, and so on, were candidate variables for multivariate analysis. And in multivariable analysis, age, residence, husband's educational status, social support, COVID-19 pandemic, and history of child days were statistically significant with this outcome variable. When you see the age variable, age greater than 35%, 35 years of age were 2 times more likely committed IPV than those less than that. So this was comparable with the study done in Wellagga zone and DDH's 2016 and the study done in Debre Marcos. So the reason may be since as the age advances, the age of the marriage also increase, so there may be chance of committing violence by her partner. So also those who is lower age may be unmarried, so they may be safe from possible perpetrators. So residents, those who are rural residents were 3 times more likely experience IPV than those who are urban. The finding was supported by the study in different regions of Ethiopia. So rural residents are low socioeconomic and educational status. So when woman herself perceives sometimes accept violence as normal. When we see the husband's educational status, those husbands with educational status of more than diploma or above were 35% less likely commit this violence. This may be due to education may change the mindset of the people, and also educated people's way of communication may be better than those who are uneducated. So the other one is child days. Those who have previous history of child days were 2.58 times more likely experience this IPV. This may be due to those who had grave history related to child loss had most likely disappointed, so they may commit violence on their wife. So the finding was similar with the study, EDH's study and the study done in Bali zone. So the other one is social support. Low social support were 3 times more likely experience this intimate partner violence. The study was comparable with the study done in Tanzania and Dilla town. So those who had low social support by her family may lead to negligence and carelessness of her partner. So there will be violence. Timing of intimate partner violence. This was intimate partner violence after COVID-19 and before COVID-19. Those there was 4.9 times more likely this violence was committed, 4.79 times more likely than before the pandemic occurrence. The reason may be during the COVID-19 pandemic, there is a vicious circle that there is lockdown and stay at home, keeping them at home long period, leading to low socioeconomic status, and they may spend long time at home. So there may be conflict between each other. So there will be violence. As a conclusion, 2 in 5 women undergo one type of violence in the study area. So the occurrence of a COVID-19 pandemic has its own impact on violence, age, residence, husband educational status, history of child days, and so on, were independent predictors. So it needs more work, cooperation, and integration of different stakeholders to avert this violence in the society. So because all forms of IPV have great impact on women's life throughout her rest of life. So this study alarms the concerned bodies who are expected to work on averting the problem and educating the community. So as recommendation based on the finding, healthcare providers should provide health education and community awareness by using different voice of communication. Policymakers develop policy to educate the community and empower the women, and stakeholders prepare different awareness ways and education for the community. As strange as the study was done during the pandemic, and the limitation of the study may incur recall bias, and due to cultural sensitivity of the issue, the women may respond culturally acceptable and report. So there may be social desirability bias. And the last one is difficulty of classifying the determinant factors, whether they are occurred before the pandemic or after the pandemic. For example, when you see the age of the woman, there may be throughout time. So at which moment the violence was occurred, it's difficult to assess this timing. So lastly, I would like to acknowledge Work University, my colleagues, and Gurage Zone Office and data collectors, study participants, and the coordinators of the symposium. Thank you very much. If you have any suggestion, question, you can welcome. Thank you.
Thank you, Mr. Solomon. So I will call upon the second presenter, and we'll have a question and discussion session next. So the second presenter is Briye Desalegn. The topic is sexual violence against female students in Ethiopia, a systematic review and meta-analysis. Briye Desalegn has completed his master's degree from University of Gondar in Masters of Public Health in Reproductive and Child Health. He has also more than 5 years of work experience in clinical areas and more than 6 years of teaching experience. He is a lecturer of reproductive and child health at TEDA Health Science College since 2019. He has experience in conducting primary research and systematic reviews and meta-analysis. He has over 14 research articles which are published in reputable journals.
Okay, good afternoon. Thank you very much, moderator, and I really thanks the symposium organizers for presenting our researches from here. Our research title is Sexual Violence Against Female Students in Ethiopia, a systematic review and meta-analysis. Okay, here are the presentation outlines. Sexual violence is prevalent problem globally. There are a number of females which are affected with sexual violence all over the world. So this is the most public health problem, including in Ethiopia. Sexual violence among female students is one of the dimensions of gender-based violence. There are different forms of gender-based violence that can be affect females or women in general. So sexual violence is one of the forms of gender-based violence. So many adolescent women initiated their first sexual intercourse with coercion or with violence, so which can expose them for different health, reproductive and sexual health consequences. So in Ethiopia, around 60% of women have forced sexual violence once in their lifetime. So it's estimated that globally around from 12 up to 25 of girls suffer from sexual violence. So sexual violence ranged from non-physical initiation for sexual intercourse without her desire up to penetrative sex, which is forced rape. So around 25% of individuals or females can suffer from sexual violence globally. So forced sexual initiation exposed victims or women for different sexual and reproductive health problems. So they made for unintended pregnancy. While there is sexual violence, individuals or females may not be initiated or use condoms or other contraceptive methods. That's why they may be may have unintended pregnancy, which is mostly end up with unsafe abortion and other sexually transmitted infections. So students who had sexual violence were more likely to report low school performance and dropout. So this is the other consequence of sexual violence among students. Sexual violence can lead to a variety of serious social and personal consequences. Those victims may develop low self-esteem or shame, mistrust, and other personal consequences. So both social, personal, and reproductive health consequences can be happen whenever there is sexual violence. So we community sanction against perpetrators play a great role of sexual violence against female students, not only female students. If the community can attack or can control those individuals or big criminals, so sexual violence is expected to be declined. So there are a number of studies which has been done in Ethiopia, but their prevalence or their report is greatly varied. So thus researchers or those individual studies did not systematized or didn't pulled. So we therefore the main aim of this systematic review and meta-analysis is to determine the full estimate of sexual violence among students in Ethiopia. So the main objective of this systematic review is to determine the pooled prevalence of sexual violence among female students in Ethiopia. So to determine the pooled prevalence of sexual violence among students in Ethiopia, we use different methods. So the first thing is search strategy and information source. Studies or fragmented studies has been retrieved and searched from a variety of electronic databases, including PubMed, Hinari, Web of Science, Scopus, and others. So to search the studies, we use we used K-terms. So K-terms has been developed and they have been used with Boolean operators and other transitions with or and. So the searching was carried out from the 4th to 28th of March 2020. So eligibility criteria, we used some standard eligibility criteria that included studies which has been studied on female students. The area is only articles conducted in Ethiopia were included. Study design, actually those at first, we tried to see a number of study designs, but unfortunately, all the studies which were included were cross-sectional and publication up to the last date of publication, and language literatures, which is written in English, were included publication. Those studies which has been published on, involving female students only. So studies focusing on both males and females, but which do not report on both separately has been excluded because we didn't get the appropriate data of female students. So all the studies which has been included were assessed for risk of bias and their quality before inclusion. So two authors independently assessed the quality of each studies, and the quality of each study were evaluated by using JBI critical appraisal checklist for prevalence studies. We used this checklist because of all the studies were reporting prevalences and they were cross-sectional studies. The data were extracted using a Microsoft Excel spreadsheet and it was exported into Stata. Two reviewers extracted the relevant data such as the name of the first author, study region, setting, study design, sample size, response rate, and the prevalence of sexual violence among students were extracted from each individual studies. So the study outcome, the main outcome of this study was the prevalence of sexual violence, which was defined by unwanted sexual acts as a verbal joke, question for sex, unwanted kiss, unwelcome touching of women's body parts, such as breast, genitalia, forced sexual attempted, forced sex by any person, regardless of their relationship of the victim. So this was the definition for the outcome variable. Data analysis and synthesis. The data were imported into Stata version 11 after it was extracted in Microsoft Excel. So the pooled estimate of sexual violence was executed with its own correspondent 95 confidence interval. Heterogeneity among the included, across the included states was assessed by using Cochrane Q statistics and inverse statistics. A random effect model was computed as heterogeneity was exhibited among included studies. Subgroup analysis was conducted based on study settings or educational institutions, and publication bias was assessed using Eger regression test and symmetrical inspection of funnel plots. And the other thing is sensitivity analysis was conducted, whether a single study was violating or influencing the pooled estimates. So the result indicates there was no a single study that influences the pooled estimates. Study selection and characteristics. To select studies, we used a Prisma chart flow. So initially 741 articles were retrieved from different databases. So those studies were screened for by their title, abstracts, and full texts. So finally, 13 studies were included for the final meta-analysis. So all included studies in this review were cross-sectional. So a total of 5,663 participants were involved from the 810 sample size, and yielding 97.5 response rates. The 5,663 is actual participants, but 5,810 are the sample size in each individual studies. So the lowest prevalence of sexual violence among female students were reported in Dilla town, while the highest prevalence of sexual violence was reported in Atambo University, which was 76.4. So it do have a great variation. 9 studies were categorized as high quality, and 4 studies were considered medium quality when we assessed them for risk of bias. So the lifetime pooled estimate of sexual violence among female students were 48.93%, which means nearly half of female students are experiencing sexual violence in Ethiopian educational institutions. So this is a result of from random effect model, which indicates the heterogeneity is 98%, 98.9% with p-value 0.00. So the pooled estimate of sexual lifetime prevalence of sexual violence among female students was 48.93. So in Ethiopia, nearly half of female students experiencing sexual violence in their lifetime. The reason could be those female students attending in different educational institutions are more vulnerable due to their relation with male colleagues, friends, teachers, and other community members. And the finding implies the need for evaluating the existing availability of information or system in general on sexual and reproductive health, as well as gender-based issues in educational institutions. So we try to execute a subgroup analysis based on region and educational institutions. So we did a subgroup analysis by making groups, university students and school students. Those school students are included primary school students and preparatory school students in one group. So higher sexual violence was exhibited or reported among the university students, which was 53.7%, while the sexual violence among preparatory and primary and secondary school students were 43.3%. This may because university students are more sexually active or immature, to say mature, and university students may lose parental control and protection as they are joining universities and they are not living with their families. Because there are a number of studies which declared that parental controlling can reduce violence among students. On the other hand, the highest prevalence was reported in Oromia region. Just we try to analyze, make a subgroup analysis based on the region where educational institutions are found. So around 60% of female sexual violence has reported in Oromia region, and the lowest was Southern Nation International Pupils region, which is 37.25%. So the possible reason might be socio-cultural differences. So the other thing, this study do have its own limitations. The study couldn't include papers from all regions of the country as there were no, and the study couldn't examine factors because of inconsistent reporting or inconsistent grouping. Factors didn't pulled. So this is the other limitation of this systematic review and meta-analysis. And some of the studies had a small sample size, which may affect the pooled estimate. So based on conclusion, the prevalence of sexual violence among female students in Ethiopia is high, with nearly half of female students are experiencing sexual violence. And there are significant differences across regions or institutions in different regions. Higher proportion of sexual violence is reported among university students than school students. So based on this finding, we try to make some recommendations. So we need to develop prevention strategies, effective interventions that may reduce sexual violence among females in educational institutions, such as strengthening life skill training and involving female students or generally, males in such a kind of information awareness programs. Educational institutional based awareness about the consequence of sexual violence should be encouraged. So the authors would like to thank those primary authors and arrange symposium. Thank you very much.
Thank you. We'll have a discussion after all the presenters have presented.
Okay, we will continue with the presentations and the discussions will be made at the end. The next presentation will be by Abraham Getachew. He is a public health professional and project management specialist. He has experience in maternal and child health, project management, monitoring and evaluation, among other public health functions. He has more than 14 years of experience, both in governmental and non-governmental organizations that gave him a broad perspective in the Ethiopian health system. He has served as an independent consultant for various non-governmental organizations, as well as the Federal Ministry of Health. And his most recent project was the Ethiopian Canadian Maternal Newborn and Child Health Project. Currently, he is working as the research directorate of St. Paul's Hospital Millennium Medical College. So Abraham will present his work on maternal child health service uptake and lesson learned during COVID-19. So Abraham, please come to the presentation.
So thank you very much, Dr. Ahmed, for the generous introduction. Our research will be on maternal and child health service uptake amid COVID-19 in public health facilities. Next, please. So this is the presentation outline that I'm going to share the findings of the research. So as a background, while we developed the research proposal in December 2020, the global distribution of COVID-19 pandemic was that much, and early in November 2021, we could see that there is a dramatic increment in infections and diseases in relation to COVID-19. So the COVID-19 pandemic caused significant disruption of essential health services, especially in sub-Saharan Africa. And this has also affected the service provision resource allocation to be shifted into other general service deliveries in relation to the pandemic. So vulnerable groups, especially women and children, were disadvantaged because of the COVID-19 pandemic. So UN and UNFPA have developed a report showing these findings. Next. So in the Ethiopian context, a study done in West Shoa indicated that the overall MSH service utilization has been dropped by 64%. And understanding the effect of COVID-19 during the pandemic on MSH services and documenting the lessons learned during the pandemic could be a paramount importance, because we are still in the pandemic and we don't know what's going to happen next, and the waves could come and other pandemics could happen in future. So documenting these lessons and having a strategy is having a paramount importance in developing strategies before services are negatively affected. So the general objective of this study was to assess MSH service uptake amid COVID-19 in public health facilities and to document the lessons learned. The specific objectives were to compare the pattern of RMSH service utilization between the pre-COVID and during COVID era in Ethiopia. So we considered 9 months before the COVID outbreak or pandemic and 9 months after the pandemic. And the other thing is to explore the lessons learned at the public health facilities. So we used a mixed design composed of both institutional cross-sectional institutional based study, which is triangulated with qualitative design with a phenomenological approach. And we randomly selected 25 public health facilities. Out of them, 80% were health centers and 5% were public health hospitals. The subcities were randomly selected, which were Arada, Bole, Kolfe Karanio, Nefas Silk, and Yeka. And the health centers are listed here, 20 of the facilities, and 5 hospitals were randomly selected. So for the qualitative purpose, we purposely selected policymakers. As an operational definition, we used policymakers, those who are directly engaged in development of guidelines and policies, who are working at the ministry level, regional health bureau, and sub-city health offices. And we have also interviewed service providers and facility directors. These policymakers, providers, and facility directors were approached directly on face-to-face interview, in-depth key informant interviews, and 15 clients were interviewed through telephone using in-depth interview guides. So the proposed period for the study was March to November 2019, to consider it as a pre-COVID era. And during the COVID era was the same months of the pandemic, from March to November 2020. And the data collection was from January to that of March 15. We developed the proposal in December, so we consider the periods before the development of the proposal. The tools and the approach we used were interview guides and we used both key informant interviews and in-depth interviews to explore experiences of service providers and women. And we used 4 women data collectors or female data collectors purposely, because we are going to use phone interview to approach the women who delivered at the facility during the COVID period. So to get an acceptance through telephone call, we used the women data collectors, and we used Open Code 4.03 to manage the qualitative data. Thematic analysis was used to analyze or to present the data for the qualitative study. And we used the Excel extraction sheet for data collection of the quantitative study. So regarding the eligibility, which means whom we included and we excluded, we considered health facilities which were providing the service for at least 2 and more years, because these facilities shouldn't be at the stage of infantile, so that their service provision couldn't be negatively affected, or not, the community couldn't know their service as well. So we used their deep-rooted service provision for at least 2 to 3 years, and health facilities which are not labeled as COVID treatment center only, or which are not closed for the purpose of COVID-19 isolation and treatment, were excluded. And we purposely selected women who delivered from May to June 2020, so that they could have an exposure of antenatal care before COVID and during the COVID era. So these women were at the 2nd and 3rd trimester. And facilities which were having major incomplete documentations or data were excluded from the study. And the services which we consider were these, and ethical considerations like obtaining an IRB approval from Saint-Paul and obtaining a support letter from the Addis Ababa Regional Health Bureau was done, and all the privacy, confidentiality, and other ethical issues were maintained. So for the qualitative study, the demography, which is excluding the women, because all women are female. The other participants, 19 were female and 15 were male, and this is their educational and age distribution. When we come to the service utilization or uptake, around 24%, which is around 24 of the facilities were having dual purpose, which means they were having isolation unit plus providing the service of pharmacy service. And the major reductions in service uptake were BCG at the first 3 months, which means March, April, and May. There was a dramatic reduction of BCG service provision or coverage by 31.9%. And the 9 months cumulative shows reduction in 12.9%. And polio 0 was reduced by 28.2, and the 9 months cumulative was 15.4. Penta 3 was reduced by 2.03, and the 9 months was 4.3. So there was a dramatic reduction of service uptake or provision at the early stage, and there was a little bit reduction, but still the service uptake was negatively affected. Vitamin A and the measles, which was administered at the 15 months, was decreased by 11.4 and 3.8. And throughout the services, some activities were still maintained, and majority of the vaccine-related services were negatively affected. So this bar graph shows the comparison between the 2 years, the 2019 and 2020. So when I say 2090, it's the calendar, but the months were considered in Ethiopian calendar because the reportings were done in Ethiopia and the initial index case was detected in March. So we consider Magabit as an equivalent month of March. So as you can see, the cumulative 9 months service uptake of BCG vaccination was reduced, and you can see vitamin A, measles at 50 months were reduced, and polio 3, you can see the reduction. So the other major drop was observed in under 5 OPD uptake or MNCI. So we observed a reduction of 48.3% in the OPD follow-ups or in the OPD cases of under 5 children. And while we see the MSH related activities, safe abortion, post-abortion, and SCVD were reduced by 24, 16, and 12%. Regarding PMT and antenatal care, we observed that the antenatal one was not as such significantly affected, but ANC4 was dramatically reduced. So this shows the distribution of the service uptake, and as you can see, almost half of last year, the pre-COVID service uptake in under 5 OPD was reduced, and you can see CS delivery, emergency deliveries, were the contributing factor for increased number of CS, but NEC1 was maintained, and NEC4 has shown reduction with that of SCVD deliveries. The other thing that we found from this study was most of the findings, which are already published in the reports generated, were showing an increase in days. But the cumulative days from the facilities that we have gone through have shown a reduction. Neonatal days, maternal days, stillbirths were reduced, and there was some inconsistency of the reduction and increment among the facilities. But the qualitative finding shows that most of the diseases were not reported at the time of COVID-19. And some respondents from the qualitative finding reflect that these diseases could happen at the community level, but couldn't be reported at the facility level. And since our source of data is facility record, these diseases couldn't have been recorded. And there were some policy-related pressures not to report diseases at the time of COVID-19 pandemic. So this might affect the reduction of disease reports in relation to neonatal and stillbirths. But there are still some outliers of the qualitative finding, which we could see in the next slide as so this was what I have already said. Previous studies from PAS indicated the rapid assessment of essential service, reduction in vaccination coverage, overall child vaccination, and essential maternal and health service intervention from 9.8 to that of 51.9% reduction. And COVID has compromised the capacity of health facilities to sustain essential RMNSH service, and the crisis barriers such as lockdown, curfews, and risk for infection prevention, prevented women from accessing health facilities, so that services like ANC, PMCT, and MNCI could reduce. But as I said before, the diseases were reported less than that of the other findings. So as a reason or a justification for the reduction, the qualitative finding shows that COVID has hindered providers from practicing compassionate care. It created service interruptions. It challenged the quality of MSH service with the scheduling, which is the proper scheduling of follow-ups in ANC and child vaccination. So it led them to reschedule the follow-ups and minimize the visits into the facilities. It exacerbated medication and supply problems, which was already existing in the system, but COVID has exacerbated that problem because of different issues in relation to purchasing and procurement, lending and taking items from facilities, which has already the stock. So in fear of COVID-19, these issues has aggravated the problem. And the finding from the ministry indicated that preparation of essential non-COVID-19 continuity plan or guide was optimal in its timing, so that through time the services were returned back on track. So these were some of the quotes I selected for the sake of this presentation. So provider from a hospital indicated that the case and days reporters on air, this is in relation to the misinformation or the way how communication has been dealt with. So the case and days reporters on air during the news in all the broadcast was more frustrating than informative. And this might be intentional to let people take their own measures, but it has led us to be overstressed. So this indicates that there was some sort of anxiety, fear of COVID, and a response from a policymaker indicated that COVID was a big challenge in their message service. He explained that when I hear that the first confirmed case in Ethiopia, I was frightened. I thought in our country's context, infrastructure, technology, skilled manpower, community beliefs and living standards, it's difficult to manage COVID-19. So they share that the policymakers or the higher officials share the same problem or fear that the community at lower level could have. So there are some quotes in relation to the fear. Next. The other discrepancy which I mentioned earlier was a hospital provider indicated that there were high number of neonatal deaths because of COVID-19. So he said, when we compare the number of newborns that died from outbreak with that of the newborns who died with asphyxia and sepsis, is greater than those who died with COVID-19. So that COVID has created neonatal deaths, but there was some gap in reporting or sharing the data. Next. So these were the themes in the quotes. Next. So for the sake of this presentation, I will focus on the lessons. So this COVID-19 has given a lesson to improve the infection prevention practices of health providers, it exposure teams of health professionals to practice actual pandemic management and organize task force to strengthen their supervision, to develop context-based message, to proper utilization of technology, to conduct virtual meeting, reporting with that of Telegram, and improved the WASH facilities of the WASH practice of facilities. And it has increased the chance of obtaining resources from the community or community mobilization. Resource mobilization has been a great lesson. Next, please. So as a conclusion, COVID-19 has significant negative short-term impact on NEC4 and PMTCT, vaccine coverage, and under 5 OPD visits. And the qualitative finding reveals with that of the finding of the quantitative one. So the pandemic has brought challenges and opportunities to the health system that needs a vigorous infrastructure and resource ready to be ahead. And preparation of essential non-COVID-19 continuity plan was timely, and compensation mechanisms, as indicated by other findings, we would also like to recommend on that. And we need to have adaptive plans or flexible plans for the service continuity and proper communications to address message by responsible bodies. And in relation to the adaptive plans, one of the main finding was having a platform of resources for epidemic management, because the procurement and purchasing process of the written system is a bit challenging for emergency or pandemic management. Thank you so much. And I will have the acknowledgement section.
Thank you, Abraham, for your presentation. The next presentation will be by Dr. Azeb Asamino. Dr. Azeb is a psychiatrist working at Addis Ababa University. She has co-authored a freely accessible Amharic guidebook for public health regarding prevention and intervention of child sexual abuse. And it has been translated to several local languages. She has served as a board member in the Ethiopian Medical Women's Association, and she is also an award recipient for the Young Physician Award in 2020 from Ethiopian Medical Association. For the sake of time, please keep your presentation in the designated time. You may start.
Okay, thank you for the introduction and for inviting me to present in this symposium. I'm presenting this research findings on behalf of Dr. Salam Meshatu, who could not be here with us because she's on maternity leave. This research is a part of a larger project, which is a collaboration between the Ethiopian Medical Women's Association and Impala Communication, which is focused on increasing the involvement of women health professionals and students in women's health care. And this is through evidence generation and health communication. So coming to this research, COVID-19 has affected the continuation of essential healthcare services and the management of health professionals redeployment. And sexual and reproductive health services may have been overlooked, as you have heard from today's panel discussion, as well as from other oral presenters. And prior to the COVID pandemic, there was already a gap in the delivery of sexual and reproductive health services in Ethiopia and, of course, worldwide. To look at some researches done, I'm sure the previous presenter has already covered a lot of research studies done in this area as well. But to mention a few, in the UK, there was a report of reduced family support, low number of ANC visits, and home-based postnatal care. And there was also a report of a rise in mental health needs during pregnancy and the postnatal period. And in the Philippines, there was also a report of a 30% reduction in the utilization of ANC by pregnant women after COVID-19, especially in the first few months. And the UNFPA projection predicted that around 40 million women in low and middle income countries will be unable to use modern contraceptives over 6 months of social restrictions due to COVID-19. Some local studies also had similar findings. For example, in St. Paul's, which was done in 2020 by Bella and his colleagues, there was a report of deliveries decreased by 1/3, immediate postpartum family planning that's decreased by 2/3, comprehensive abortion care that was reduced by around 20%. And in this, a similar study was done by Temescan and colleagues, and they reported cancellations of regular ANC visits due to COVID-19 and worsening of prenatal and postnatal care delivered, and also in abortion care and the use of contraceptives. So our objectives were to provide a national overview of trends in the account of women and girls regarding the impact of COVID-19 pandemic on the sexual and reproductive health services. And we wanted to assess some specific services, which is the antenatal care, labor and delivery services, postnatal care, post-abortion care, access to contraceptives, and the perception of the women regarding their mental health during this period. And we looked at 4 hospitals which were associated with the Ethiopian Women Medical Association. These were Arba Minch Hospital, Debre Marcos Hospital, Gandhi Hospital, and Awasa hospitals. The study population looked at consenting adult women who were receiving sexual and reproductive health services during the data collection period, which was in May 2021. We focused on women who are receiving postnatal services, as well as people receiving family planning services in this period. And we also focused on healthcare workers who are providing sexual and reproductive health services. We used the cross-sectional mixed qualitative and quantitative methods. We also looked at HMIS data 1 year before and after the COVID-19. We took March 2020 as the cutoff point. And we, for the quantitative collection, we used the single population proportion formula with 10% response rates, and convenience method was used to select participants in consecutive manner. And for the qualitative interview, we used a purposive sampling to select a mixed group of both service users and healthcare providers in this 4 hospitals. And the data was collected by trained women general practitioners in these hospitals. And the analysis was used, descriptive analysis and narrative analysis was used to report the results. Ethical approval from each institution was obtained, and also a support letter was given from the Ministry of Health. And the consent was taken for each respondent, and storage was anonymous. COVID-19 precautions were applied during interviews, and data collectors were GPs who could respond to any medical issues, but there was no incidents during the interviews. So when we look at the general information about the respondents, we had 369 respondents. 198 of them were multiparous women, and 51 of them had obstetric complications, and 129 of them had delivered through spontaneous vaginal delivery. We did 25 in-depth interviews. 3 healthcare workers and 3 service users were selected from different institutions, and 1 additional person from one of the institutions. The HMIS data was also reviewed for each institution. So when we look at the collected data from these 4 hospitals, when we look at the ANC visits, you can see that the first visit was decreased by 31% when we compare the pre-COVID and post-COVID era, as well as the 3rd visit. You can see that in general, there was a significant reduction in the ANC visits. When we look at the route of delivery, this was an interesting finding because there was a decrease in spontaneous vaginal delivery, but there was an increase in cesarean section deliveries, which was about 14%. This was consistent with some findings in China and European countries, where they say that there was, this might be explained by an increased complications due to the lack of ANC visits, as well as it could be that physicians are choosing the cesarean section method due to fears of complications during labor. In our study, we didn't find any difference between maternal days before and after COVID. There was an increase in safe abortion services, but there was a decrease in post-abortion care. Regarding the contraceptive use, there was a decrease in the use of pills and injectables by 23% and 10%. Respectively, but there was an increase in the use of permanent contraceptives. And this was an interesting finding for us, but we thought that it might also be related to the increased complications, and it might be related to the increase in the cesarean section as well. But this might need a further look and in-depth look into the charts of these patients. With the qualitative and the quantitative interviews, we found in the questionnaire, we found that 27% reported the reduced quality of care due to COVID-19, and 12% of them said they received inappropriate ANC care, and 34% reported a reduced ANC visits, and 24% of them knew at least one person who missed their ANC visits due to COVID-19. The reported reasons were fear of infection, travel restrictions, canceled visit by hospitals, lack of medical COVID-19 protective equipment in the hospitals, and shortage of medical professionals in these services. One service user reported that we used to come for follow-up every month, but now it's every 3 months because of the virus, and we run out of iron capsules sometimes. Regarding labor and delivery, 17.2% of them reported reduced quality of care due to COVID-19, and 4.4% of them reported inappropriate care. And 62.7% expressed reduced family support during labor and delivery due to limitation of visits related to COVID-19 restrictions. And this is also a consistent report from other studies as well. Regarding postnatal care, 16.9% reported worsened postnatal care due to COVID-19. And out of the 134 women respondents who delivered in the hospital, 40% of them stayed in the hospital for less than 24 hours post-delivery. One service user reported, because there were lots of mothers delivering during the pandemic, we were told to leave the hospital earlier than we had to. And she wondered what if we had late bleeding, and she said that was a difficult experience for her. Monitoring post-delivery was less frequent in the first hour post-delivery in 58.7%. They reported that healthcare workers were few and busy. So for the 58.7%, the frequency of monitoring post-delivery was every 30 minutes or every hour. Healthcare providers, one healthcare worker said healthcare providers are testing positive for COVID-19 and they leave work. The remaining ones have to cover a lot of work, and the quality of care suffers in the middle. And he said, I can no longer follow a mother every 15 minutes. Regarding contraceptives, they reported limited access to contraceptives due to COVID-19 related restrictions. 3 women reported having unplanned pregnancy due to lack of access to contraceptive use, which is related to travel restrictions. And out of 16 women who had abortion during the COVID-19 pandemic, 12 of them said they had received post-abortion care at the hospitals and they found it to be inadequate. Regarding gender-based violence, one of our respondents, a healthcare worker, said that people were very sensitized about sexual assault after mass media work. They would bring their children just to be checked if they are assaulted, and it was shocking as a community. But please note that we didn't have a questionnaire for the service users regarding gender-based violence. Regarding mental health, our respondents reported increased levels of COVID-19 related stress that occurred after delivery. They reported that they had increased worry of infection to themselves, to their newborn, and to their close family members. And there was a similar report from a healthcare worker as well. So in conclusion, there is a reduction of quality of reported quality of ANC, labor, postnatal care, post-abortion care, access to contraceptive use that are due to COVID-19 related restrictions, and reduced number of sexual and reproductive health personnel, medical personnel. And COVID-19 has also contributed to increased stress to mothers of newborns. most study findings were comparable to other local and international studies. Some recommendations we had was to provide updated information to ensure the continuity of essential services during COVID-19, to provide guidance on self-care seeking behavior, and including wearing masks, physical distancing while visiting healthcare institutions and in public spaces, and ensuring the adequacy of healthcare providers to provide essential services during public health emergencies, and to create mechanisms to ensure access to contraceptives during public health emergencies, and create mechanisms of monitoring and psychosocial support for pregnant women, mothers of newborns, and women who had abortion and stillbirths during public health emergencies. And we have seen that there were some important guidelines developed to respond to this, and there are some efforts to tackle this issue. So we recommended that these guidelines are disseminated more widely and to be revised accordingly. And we might need more research regarding changes in specific services during the COVID-19, such as the increase in the cesarean section deliveries and also the increase in permanent contraceptives. Thank you.
Thank you very much, Dr. Azib and the other presenters. We will have a brief discussion. We will take 10 minutes if there are critical questions. So all the presenters, please come to the podium. And my co-moderator, Dr. Abel. We'll take a couple of questions from the room. If there is any question from online audiences, we'll take that too. I see one hand. Madam Lack, you can pose your question.
Okay, thank you, the moderators, all the presenters, and congratulations for presenting your nice work on this symposium. I have few questions for three of the presenters. To start with Solomon, as all we know, gender-based violence, studies on gender-based violence and intimate partner violence in particular are prone to different challenges. The first one is methodological challenge and the other is ethical challenge. Despite this, the prevalence of intimate partner violence in your study area is 42.9%. I feel that this figure is very high for me, given most of your study subjects are from rural Ethiopia. And I want you to tell me how confident are you on this evidence and what is your validity of the evidence. And related to this, lockdowns in rural Ethiopia were not strong or they were not strict. But you have justified that the high intimate violence in the study area is due to the lockdown. So how serious was the lockdown in Gurage zone? As 70% of your study subjects were from rural Ethiopia. For Abraham, I'm very much interested with your findings, and I have got all the disparities existed in maternal health service. I have one issue regarding the antigens. What happened to other antigens besides BCG, polio, and vitamin A? For example, we use penta-3 as service utilization, as indicator for services utilization. So what happened to penta-3 and other antigens on your study? My last question is for Dr. Azeb. You have got high permanent contraceptive utilization, and was that difficult to address why high permanent contraceptive utilization was achieved by using your qualitative study? Or was that different? Was there a difference in timing of conducting your both studies, qualitative and quantitative? Thank you.
Presenters, you may address the questions. Okay, before that, I see one hand from the back and here.
Thank you very much. This is Polyphil from St. Paul Hospital Millennium Medical College. My question goes to Solomon. Given that the violence is actually a sensitive issue that hinders the services that we provide to women, I wish to know if, Solomon, have you been able to see some modifiable factors that we can actually modify? For example, some of your factors were, for example, the age, the education, and having had children of same sex that were associated with intimate partner violence. Are there some modifiables that you think you can share with the audience that we can modify? And also the second is some of good information is IPV were more likely to occur after COVID-19. Do you think it was because of the surge of the COVID-19 where people were not prepared? Do you think it could be the same up to now, that people are more prepared about COVID-19 than at the beginning? Thank you.
You can respond. Mr. Solomon, you can start.
Okay. Thank you for your interesting questions. So the first question is the validity of the result. I think it's due to the questions that we ask. There are certain questions we are asking certain questions from that. There may be sexual violence, physical violence, or emotional violence. So the woman who said yes for one question is already her partner committed violence, so that may cause inflation of the result. So I think I am not that much confused with this result, because the woman with one result or one question, she said yes, she is already violated by her partner. So the second question is the lockdown of rural areas. Actually, at the beginning, even though they are rural, for about 3 weeks or 1 month, there was appropriate lockdown. So that may cause confinement of those both partner and his wife in confined area. So that may cause violation. So the other question is, we use certain questions to assess the violation. So one question may be, does your partner insults you? So that may be, if she says yes, she's already. Yes.
A single question, then the intimate partner violence. That will lead to a higher prevalence of intimate partner violence. That's the reason.
Thank you very much, Mr. Moderator. So the other question is modification of the variables. What I want to say is just we modified to the local context or understandable way of the question, not that much basic. There is no any modification of basic question, but to easily understandable, we just modified the wording or the just the communication easily understandable to make the question is easily understandable.
So if you understand his question is from the factors that you identify to predict intimate partner violence, which factors were modifiable so that in the future which can be modified. For example, age is not a modifiable factor.
Yeah, we didn't just modify variables like age, residence, and so on, but the question is from, for example, to assess violence, we took certain questions from WHO, so to make easily understandable by the community at that local area. So just we make easy the questions rather than just the variables. The other question is, do you think this the prevalence is similar at current time? We don't have any justification to say it may be continued similar or not. It needs research or other way of communication. So we can't say it may be similar currently, or it may be decreased, or it may be increased. So thank you very much.
So thank you very much for the chance and the question from Mr. Andamlak. Regarding the other antigens, we considered all vaccines which were to be given for a newborn, starting from BCG, oral polio vaccine 0, and the like until the measles, which is going to be given at the 50 months. But what I've presented is the ones which show consistent reduction at the first quarter and the total 9 months. But there were some ups and downs in the other vaccine uptakes. And some of the justifications from the qualitative study were there was some vaccine shortage, transportation related issues, and a problem of lending and taking vaccine from subsidies or health facilities which are found nearby, which was a practice before the COVID-19 pandemic. So I just present the ones which have a dramatic fall or reduction, but there were observed variations or reductions in the other antigens, but it wasn't as such significant. Thank you.
Thank you for the question. I think the question was regarding the permanent contraceptive use. That data was extracted from the HMIS data from the 4 hospitals. It was not through the questionnaires or the in-depth interviews. And in that data, what we found was prior to COVID-19, for the entire year, there were 46 people who used permanent contraceptive methods in these institutions. But after COVID, there was 64 women who used permanent contraceptives. So when you actually look at the numbers, it's not a large increase, but it's an increase that we may need to pay attention to, and we may need to try to explain it in some way. For us, we tried to look for other studies which could explain this, but we couldn't find anything that reported an increase in permanent contraceptives. But what we hypothesized is that because usually in our practice, permanent contraceptives are usually done during cesarean section or during other surgeries. That it might be either a complication that resulted in those surgeries, or the women requested this permanent contraceptives with the cesarean section use. But we may need to look further into this to explain it. If you look at the differences in the contraceptive use in the pills and injectables, however, you can see that there is a large number increase. It's an increase in hundreds of women when you compare it to the permanent contraceptive use.
So thank you all the presenters for your nice presentation. We'll close our session. Thank you very much.
And the moderators as well. So in the interest of time, we are a bit behind our schedule. So we should have broken for about 10 minutes, but we are not going to do that because of time. You can stand up and stretch a bit wherever you are as I'm introducing the next session. So the next session is a very important part of today's one of the very important parts of today's deliberations. So we are going to have a state-of-the-art lecture that's going to be on advances in medical abortion. So the session is going to be moderated by Dr. Tasfay Hurisa. Dr. Tasfay Hurisa is an associate professor of obstetrics and gynecology with subspecialty training in family planning and reproductive health. He has more than 11 years of national and global experience in reproductive health with special interest in research, policy, and programmatic works. He has published scholarly researches in both national and global reputable journals. Currently, he is serving as director of St. Paul's Institute for Reproductive Health and Rights. Dr. Tasfay will introduce the speaker, and I would like to invite him to chair the session. Dr. Tasfay.
Thank you very much, Dr. Makati, for a nice and generous introduction. Maybe I want to remind everyone that we have a reception following the state-of-art lecture, so I advise everyone to stay behind after the next event. So before proceeding to the next event, as we are happily conducting this symposium, I want to express how deeply sorrow we are, or how deeply pained we are due to the ongoing conflict, and also due to the women and girls who we are daily working to improve their quality of life, their reproductive health and rights. At this time, as we are conducting our symposium, the girls and women of our own are suffering from sexual violence, and we really hope that this suffering will stop at some point in time. So saying this, I would invite the next state-of-art lecture. So the next state-of-art lecture is a video recorded one. It is presented by Dr. Natalie Kapp. She's an obstetrician and gynecologist trained in complex family planning, and she's currently the chief medical advisor for International Planned Parenthood Federation. She has over 70 peer-reviewed publications, including original research and systematic reviews. Her most recent research includes the safe use of medical abortion in over-the-counter like settings, expanding provision of medical abortion after 13 weeks gestation among mid-level provider, and reducing barriers such as ultrasound requirements prior to abortion after 13 weeks of gestation. So the topic of our presentation will be an advances in medical abortion. So she has summarized the current trends in use of medical abortion in termination of pregnancy. We are very much privileged to have such a remarkable scholar in our symposium. Thank you.
Hello, I'm Natalie Kapp, and it's a pleasure to speak to you today about the state of the art of medical abortion. I just want to start by saying I'm going to be focusing on medical abortion below 13 weeks gestation, as that is where we're finding most advancements. And I also want to start by saying that at this point, we have already 20 years of evidence on the safety of medical abortion. It's a simple, safe, and effective technology revolutionizing abortion access and care, has very high efficacy, 92 to 99%. It's been used safely by hundreds of millions of women. Hospitalizations, specialized skills are not necessary, and complications are rare. Even since the inception of medical abortion, women have managed most of the process on their own, including taking the drugs, managing cramping, bleeding, expulsion, and pain, generally on their own. It's interesting to see what's happened over time. After the introduction of medical abortion in different settings, its popularity increases over time. However, the proportion of all abortions that are by medical abortion versus a surgical or aspiration evacuation varies greatly by country and by setting. And you can see I've just chosen 3 different settings here in the Scoopmacher report from 2017. And surgical or aspiration abortions is represented in the orange line, and the medications, medical abortion, is represented in the green line. You can see that in each of these 3 cases, 3 countries, Belgium, Finland, and France, that the proportion of medical abortion increases. And even in Finland and France, you can see it surpasses the percentage of abortions that are by surgical means. In the US, medical abortion is about 1/3 of all abortions that occur at less than 12 weeks. So how does it work? Well, mifepristone is the first drug of the combination drugs. It's a selective progesterone receptor modulator that acts at the progesterone receptor and blocks its ability to respond to the endogenous hormone. And you can see here in this schematic that progesterone normally binds to this receptor, and that mifepristone, or RU486, actually blocks binding and doesn't allow transcription to take place. And what that means is that that progesterone is blocked, and because progesterone is a requirement for maintenance of pregnancy, it disrupts its action at the receptor site and has these following actions. They're all pictured here in the schematic on the left. You can see that it starts by initiating breakdown of the endometrium, and then this blocking action of progesterone causes detachment of the embryo, a decline in HCG, and further declines in progesterone lead to further breakdown of the endometrium, enhanced contractility of the uterine muscle, and softening and dilation of the cervix. Misoprostol is the second drug of the medical abortion combination, and it's taken after mifepristone. It's a prostaglandin analog that stimulates uterine contractions. It's inexpensive, it's stable at room temperature, and readily available in most countries. It's commonly used for gastric ulcers. It's administered through many different routes effectively. Already in obstetrics and gynecology for a number of uses, including treatment of incomplete or missed abortion, induction of labor, cervical preparation, and prevention and treatment of postpartum hemorrhage. The regimen for medical abortion at less than or equal to 10 weeks you take is the following. You take mifepristone 200 milligrams orally on day 1, and then 1 to 2 days later, misoprostol 800 micrograms buccally, sublingually, or vaginally is administered. This normally happens at home. So the woman administers the drug on her own. And then follow-up can happen to ensure that the pregnancy was passed without problems. 8 to 16 days later, this is optional follow-up because of the high degree of efficacy of these drugs. So this is not a required visit, but one that can be undertaken by a woman and a provider if it's preferable to her. There are some contraindications for medical abortion. The first is ectopic pregnancy. This is because mifepristone and misoprostol don't treat an ectopic, and so an ectopic should undergo normal treatment, methotrexate, or a surgical procedure. Of course, contraindications include allergy to mifepristone, misoprostol, or other prostaglandins. Chronic adrenal failure is a contraindication because mifepristone has anti-glucocorticoid activity. Inherited porphyria is also a contraindication for mifepristone. If an IUD is in place, the IUD should be removed before the woman has an abortion procedure. And for a woman with severe unstable health problems or has severe uncontrolled asthma or is on long-term corticosteroid therapy, she should not receive mifepristone. Administration of mifepristone is quite easy. It's a small tablet, 200 milligrams. It's only 1 tablet. Most women feel nothing after taking it, although a very small proportion, around 5%, may have some spotting before she takes the misoprostol. Misoprostol is taken 1 to 2 days after the mifepristone. Administration is either by sublingual, buccal, or vaginal routes. And if it's taken sublingually, it's actually absorbed a little bit faster than buccal administration. It's put for 30 minutes under the tongue. Buccal administration is held in the cheek for 30 minutes. Same as with sublingual, if there's any pill residues at the end of 30 minutes, you swallow it. And vaginal administration has lower incidence of gastrointestinal side effects. And women should be aware that cramping usually starts in 1 to 2 hours and bleeding starts about 2 or 4 hours after taking the misoprostol. And so a plan should be initiated for the pain and the bleeding to start when she first takes the misoprostol. So let's talk a bit about efficacy or effectiveness. So success has generally been defined as expulsion without further need for treatment, but some of the older studies of medical abortion actually included an additional dose of misoprostol if expulsion didn't happen. However, let's look at 4 studies that compared weeks of gestation and plot their success rates from each of these studies. So there are 4 different studies that I have listed on this slide on the left. And what you can see is efficacy is really high, mostly above 95% for these, for all of these studies that looked at 42 days or less compared to 43 to 49 days. And then you can see that from 42 days to 70 days gestation, that the effectiveness decreases a little bit with each gestational week. However, it is quite effective still. It's very close to 95%, even in that very last week, the 10th week of pregnancy. And I have a scale, or a graph on the right that looks at the time to expulsion. And the median time in general is around 4 hours. But you can see that the 10th week compared to the 9th week of pregnancy, it looks like it might take just a little bit longer in that graph on the right-hand side. Well, what about the 11th week? Well, a recent study, this was published last year by D'Souza et al., compared the 10th week to the 11th week, so 64 to 70 days compared to 71 to 77 days in 5 different countries with a sample size that was, close to 600 women. And what they found was that that the success rates were high, what we'd expect in the 10th week, about 92%. But it was quite a bit lower in the 11th week, only 86.7%. And when you break down the reasons why it wasn't successful, what we see here in the rest of this table is that ongoing pregnancy was almost 3 times, happening at almost 3 times the rate in the 11th week. So almost 8% of the reason of those who had a failed a medical abortion had an ongoing pregnancy. And you can see that the other reasons, so persistent non-viable pregnancy or just retention of products or excessive or prolonged bleeding, didn't really differ between these 2 groups. Other data that we have on safety and efficacy from 11 to 14 weeks really come from clinical data from in-facility use. And what we see is once we hit the 11th week, really do need multiple doses of misoprostol. So it's not just 1 dose of 800 micrograms, but repeat doses of 400 micrograms every 3 hours. On average, women need about 2 to 3 doses for a complete abortion, and success rates when you are repeating the doses of misoprostol comes back up to that success rate that's close to 95%. In this one study here, Hamoda et al., they had a success rate of about 96%, and again with low rate of serious adverse events. So warning signs that women should be aware of and should return to a facility for help regarding include heavy bleeding with dizziness, lightheadedness, soaking 2 pads for an hour for at least 2 consecutive hours, worsening pain not relieved with pain medicines, flu-like symptoms that occur any day after the day the misoprostol is taken, fever or chills that last or occur after the misoprostol, syncope or odorous vaginal discharge, particularly if it's with fever and pain. So complications do occur, but they are rare. These numbers come from large case series and experience centers, so complication rates may be higher or different in centers with less experience or lower case volume. Failed abortion that is needing a vacuum aspiration for any reason, including retained products, incomplete abortion or ongoing pregnancy or bleeding, is around only 5%. Infection in medical abortion cases at less than 13 weeks is well less than 1%. Any adverse event after a vacuum aspiration abortion, just in comparison, is about 1.5%. So current medical abortion services in most places currently look like women take these drugs home and manage the medical abortion process on their own. This is up to about 10 weeks gestation. They take the misoprostol at home. Some take the mifepristone at home too. Some actually swallow the mifepristone in the facility or in the clinic. Women manage the cramping, bleeding, expulsion, and pain on their own. And as I mentioned before, they may seek follow-up care, but it's not a requirement. As comfort with the process of medical abortion amongst both women and providers have increased over the last decade, we have increasingly seen women accessing abortifacient medicines through many different mechanisms, particularly where abortion services are restricted or access is difficult, but also in settings where women have many options and they choose some form of self-care. So we're seeing many opportunities for women to use telemedicine or websites, and two of those are pictured here on this slide, Women Help Women and Safe to Choose. In some countries, there are hotlines or accompaniment models, and we have recent data from South America on accompaniment models that were published by IBIS Reproductive Health in the last couple of years. And then women are also not seeing a physician or talking to a provider at all, and just sourcing their medical abortion drugs from pharmacies. Well, the bulk of the data that we have thus far on some of these more non-traditional routes of obtaining medical abortion are coming from telemedicine provision, and I have two different recent articles that are pictured here on this slide. And these models have become much more mainstream during COVID-19. And these services are limited generally to up to 10 or sometimes up to 12 weeks gestation. These population-based studies report on women who've provided their information to the service. They've received some kind of counseling, usually in writing or sometimes with an actual video interaction with the provider. They receive medicines either, well, generally they're posted their medicines, and then they report their follow-up data back to the service. High success rates are reported generally, and in these cases, 95% reported a successful medical abortion, and there have been few safety concerns. Approximately 10% of women in these services report some kind of self-reported sign or symptom indicating the need for medical attention, and less than 3% actually had some kind of medical intervention that included antibiotics or blood transfusions. And in light of these kind of recent and clear data about these various methods of abortion care, the World Health Organization has said that abortion self-care is safe for women up to 12 weeks gestation with access to information and health services if needed. IPPF, who's my employer, just issued a statement in June from the International Medical Advisory Panel on the topic. And it reiterates what WHO has said about self-care, and has also said in this statement that women have the right to lead in part or entirely their abortion process with or without support from health providers in a safe setting. This includes supporting women's health literacy, that medical care is accessible to those who need it or want it, and that there are quality abortifacient products, meaning mifepristone and misoprostol, are of quality. And what abortion self-care is not, it's not an approach that removes the duty of care away from the health system, and it's not an approach that's only necessary for legal or legally restricted or humanitarian settings. And in fact, we still, as healthcare providers, need to facilitate access to information, commodities, and needed services. I think it's also just important to remember that in some of these restricted settings, it can play a significant role in increasing access to women, reducing mortality and morbidity associated with unsafe procedures. And even in contexts with legal, quality, and comprehensive services, some women and girls may prefer or need abortion self-care. And a concrete example of this has been in the context of COVID-19 over the last year and a half, as women have seen their mobility restricted, and which has affected their capacity to access facility-based abortion care. So some key messages I'd like you to take away from this presentation. Mifepristone and misoprostol is safe and effective for induced abortion. We have plenty of research that supports outpatient use, so women using the drugs at home through 70 days gestation. There's a trend toward lower effectiveness with increasing gestational age, which tells us that you need repeated doses of misoprostol after 70 days gestation. Women should be counseled how to take the medicines appropriately, what to expect, how to manage pain and warning signs, and that telemedicine and self-care models are safe and acceptable to women and may ensure access, particularly to those women who are in restricted settings. And with that, I'd like to say thank you, and I will be taking questions.
Thank you very much, Dr. Natalie Kapp, for a very timely talk, especially at this moment where the health system is straining and women's and girls' access to sexual reproductive health in general and safe abortion service in particular is a challenge. So the issue of self-care and also changing the landscape for medical abortion is really timely. So thank you very much. Saying this, I want to open the floor for discussion. We will be accepting questions from the room and also from the virtually from the platforms. Okay, so we have two questions. We have two individuals asking questions. So we'll first give the chance to Dr. Abel and then Dr. Farid.
Okay, thank you. My question is, when do we declare a failed medication abortion? And the other question is, if the medication abortion has failed as an outpatient, can we proceed with a repeated dose of medication abortion as an inpatient or go back to surgical abortion?
Do you hear me?
Thank you, Dr. Natalie. My question will be regarding on implementation of abortion self-care. So yes, WHO came up with SRH's self-care guideline late in 2019, and it has also included abortion as one part of the comprehensive RH package to be provided as self-care. So perhaps you may tell us from your experience in other countries that the abortion self-care guideline, would that require a whole update of the national guideline for provision of abortion services? Or will it be something that you can implement within already existing health system or within already existing health service protocols? Or would it require changing the whole policy and health system service delivery and national abortion service protocols? Thank you.
Thank you, Dr. Abel. There is one question over there.
Okay, thank you. Actually, this is a state-of-art presentation, but I know that there are some clinicians here and I want to ask some clinical questions. One thing is, it says that the literature says that there is a need to repeat the dose after 70 days of gestation. So how much will be the dose? What is the maximum dose that we are going to tolerate for I think it's for the second trimester abortion after 14 weeks or something, after 70 days. Isn't it? I don't know the clinical area. When I was in clinical area, there was second trimester abortion, and second trimester abortion was said to be tolerated up to 2000 microgram. I don't know about the dose up to 14 weeks. That's why I asked this thing. And the other thing is, if it is 14 weeks and above, there will be some sort of transient survival. Is there anything that the literature says about transient survival and fetocidals? Thank you.
Okay, thank you very much. Maybe one last question, Dr. Polyfield.
Thank you very much, Dr. Nathalie. My question regards the self-abortion care. Would you suggest that a patient, for her to undergo self-abortion care, she should meet a certain criteria? And also for a health institution, are there some criteria that it should meet to offer self-abortion care?
I didn't catch that question, Polyfield. Can you repeat the question again, please?
My question regards whether there are some criteria required for an institution to offer self-abortion care to a woman. For example, if the institution does not have anyone, does not work during the night, for example, should it offer self-abortion care to a woman, and when she has a complication during the night, she doesn't have anywhere to go? And also, are there criteria, clinical criteria for a woman to be eligible for self-abortion care? Thank you.
Thank you, Polyfield. So I'll give the chance to Dr. Nathalie to respond to these questions.
Yes, do you hear me well? Can you hear
Dr.
me?
Nathalie.
I'm speaking. Can you hear me? It doesn't seem like you can hear me, but I can see that I am speaking. Oh, you do hear me. Okay. Great. So thank you for the questions. I'll start with the first question that was asked, which was about how do we declare a failure? And I think a lot of declaring a medical abortion failure has to do with what the woman is tolerating. So except for the cases where you do an ultrasound and see that there is still an ongoing pregnancy, you can still see the gestational sac. A lot of in the literature, in the studies, and in practice, calling a medical abortion a failure is because a woman is having a lot of bleeding or isn't tolerating the procedure well. So this is interesting because when places who haven't been doing medical abortions start doing medical abortions, they actually have higher failure rates. And it seems to go down over time as people get used to the kind of the amount of bleeding and the length of time it takes, and then are able to counsel the women on what to expect. So I would say a large percentage of what we call a failure, you know, those 5% of people who fail, about 4% of that is having bleeding that seems like a little bit too much, or at least to the woman it seems like it's too much. Because ongoing pregnancy rate is about 1 or 1.5%. So, you know, I would use your interaction with the woman to be the thing that would guide you to call a medical abortion a failure or not. And as far as a repeat dose of misoprostol, whether it can be inpatient or outpatient, that is also, I think, a question for the woman. some people feel like, some women feel very invested that they really want the misoprostol to work. They really want to do a medical abortion. They really don't want a surgical procedure or an aspiration. And so those people are very happy to have another dose of misoprostol. And many of them will go on to successfully, complete their medical abortion in this group of people we've been talking about, the less than 70 days. Some people would rather, when they have been having cramping and bleeding for a day, and maybe they've had a repeat dose of misoprostol, and they're still bleeding, and it doesn't seem like the pregnancy has passed, those people often just want a surgical abortion to get it over with. So except for the case of someone actively, hemorrhaging or seeing an ongoing pregnancy on ultrasound, the diagnosis of failure has a lot to do with what the woman is experiencing. Okay, so I'll take the second question, which is about whether the new thinking and the guidance from WHO about abortion self-care means that you need to update your protocols or completely change them. I don't know your national protocols and policies well enough to answer that question, but I would support integrating self-care into your existing policies and protocols rather than completely overhauling or completely changing your protocols. I think that it's a model that can fit into existing models of care already. The next question was about second trimester treatment and a maximum dose of misoprostol. There isn't a maximum dose of misoprostol. However, most people, when we look at studies in the second trimester, so after 14 weeks or so, after 13 or 14 weeks, on average, people usually expel the fetus around the third or the fourth dose. And there are, for some reason, a very small percentage of people who still haven't expelled by the fifth dose. It's just a smaller number of people, so you won't experience this very often, but there are some people who need more than 5 doses. I think it's reasonable to reassess at 5 or 6 doses. Make sure that the woman is tolerating the experience well, that she still wants to try with the misoprostol. I think if you have surgical options, you can offer to somebody who has been in the hospital for a couple of days getting misoprostol every 4 hours, to see if maybe they want to change to a D&E procedure or a modified aspiration procedure. Some people will rest for a few hours and stop giving the misoprostol. We don't have great evidence on what is exactly the best thing to do, but you certainly don't need to stop giving the misoprostol. But this is an area where, because it doesn't happen very often, it hasn't been well researched. What is the best course? I think you also asked about transient fetal survival. That becomes more common after 20 weeks, and it kind of depends on the resources that you have. There are certainly techniques that you can do before you start the misoprostol, which is to inject intraamniotic digoxin, which is a pretty easy to do, and it's a cheap medicine. It's just like doing an amniocentesis. You just put a needle into the amnion, and that's quite effective and works fairly well. It does, cause some cramping for the woman at the time of the needle insertion. But it can avoid the fetus being delivered or being expelled with signs of life. I think the very last question was about the criteria for a woman to have safe abortion care. And I'm not 100% sure what exactly what the question was, but I guess I could say that a woman who is pregnant and doesn't want to be pregnant deserves safe abortion care. And as far as the criteria for the institution, I don't think an institution needs to be available all night. I don't think you should say we can't provide this care because we don't have an on-call physician. I want to remind you that women have miscarriages, so they have spontaneous abortions all the time in places where there might not necessarily be a hospital, and people manage this process quite well, even when they're having a spontaneous abortion. And a medical abortion is very similar, very much like experiencing a miscarriage. So I think if you're in a community where people have miscarriages, you can probably also manage abortion care. I think those were all the questions.
Yes, thank you very much, Dr. Natalie. I think all the questions from the audiences are addressed. Maybe I will give one more chance if there is any critical question or anything that needs to be addressed. So I think that's all we have. Thank you very much, Dr. Natalie Kapp. We are very proud and very pleased to have you here with us. Thank you so much. And thank you, the participants, for your active participation.
Wonderful. Thank you all.
Thank you very much, Dr. Tesfaye, for moderating the state-of-the-art lecture. And we also thank the speaker for delivering such a wonderful lecture from a distance. So as I'm so sorry, I forgot to mention that we have another important social event. There will be a reception, a cocktail reception after this time. So you are all invited. Please don't go away. So before just breaking, I would like to remind you all our supporters, the gold and silver sponsors. The gold sponsor is Third Global, Engender Health, and Packard Foundation. We have also silver sponsor, which is IPAS Ethiopia. We thank all of them for the generous support and also for the work they do in improving the lives of women and girls in the country and throughout the world. Thank you so much for your participation and for the long afternoon you had. So please stretch a bit before the reception is organized. So it will be probably, it's ready. So you can stretch a bit before having the dinner reception.
you.